చాలా టెంపర్మెంట్ just ఇనిపియట్లేదు. No, I can't hear anything.
వాల్యూమ్ చేయండి ఇక్కడ కంప్యూటర్ వాల్యూమ్. ఓకే అంతే ఉంది కదా వాల్యూమ్.
రావట్లేదు కదా.
స్పీకర్
I'll check this.
మైక్రోఫోన్ అని పెట్టాను అది తీయొద్దు. తీస్తే మళ్ళీ నేను నా కంప్యూటర్కి వెళ్తాను. ఇది యూస్ చేయండి కంప్యూటర్.
I won't get the link on that.
పెట్టేసి అయిపోతుంది. సరిపోతుంది చేసినట్టు.
Very sorry, I apologize for the IT issues and we missed the start. So I will start by introducing you.
Hello?
Hello. Hello, Dr. Dipinandi. Can you hear me?
Yeah, I can hear you.
Dipti sir? Dipti.
Morning. Hi, morning, Pratap and Chandrasekhar. Sorry,
Good morning, sir.
there's a
Morning,
problem
Dr.
with my audio. So I had to change my laptop.
Okay, okay.
All done? Okay, thank you. It looks like Vivek is not on yet. Vivek is not on yet. He was supposed to be coordinating for us. Can we start the presentations or?
Yeah, I think probably yes.
Yes, sir.
Sir, it's a recorded session.
Yeah, it's a recorded session, the video recording. So good morning, everybody. We should start with the video recording session of surgical videos.
Sir, you announce one by one speaker name, then I start.
And I'll have to look at it.
The first lecture is mine, sir. First lecture is
So the first one will be by Dr. Chandrasekhar.
rotatic of repair transversus equivalent technique.
Yeah, that's the one. Thank you.
Hello, everybody. I am Dr. Chandrasekhar, Director of Shoulder Surgery, Sunshine Hospital, Hyderabad. And I'm very thankful to the scientific committee for giving this opportunity to give a lecture on this prestigious OSS conference. I'm going to speak on rotatic of repair technique and what we call it as a transosseous equivalent technique, a double row type of repair. What is the single row and double row? When you put a single anchor, a single row of anchors on the greater tuberosity and stitch the cuff to the tuberosity, it's called a single row repair. What happens in a single row repair is that the lateral part of the cuff is attached to the bone, but the middle part of the cuff is away from the bone. So it's like a kind of iatrogenic partial tear. Then double row repair, what we call as a traditional double row repair, wherein you put two rows of anchors, two medially close to the cartilage, and two anchors laterally on the lateral part of the greater tuberosity, and tie knots in 4 different points. Even though the fixation is better, but here the compression is not uniform, and here what we call is point fixation. You have 4 points of fixation. The compression of the cuff is not uniform. Now, what is this transosseous cuff repair or the transosseous equivalent? Transosseous cuff repair is the original rotator cuff repair which we do many years ago, before the advent of arthroscopic rotator cuff repair, when we use a mini open deltoid splitting approach and expose the greater tuberosity, make 2-3 transosseous tunnels with a K-wire or a drill bit, and pass sutures through these holes transosseously, and these sutures will be used to fix the cuff onto the greater tuberosity. Here there is a uniform compression of the rotator cuff. To achieve the same arthroscopically, the technique is slightly modified, wherein we use 2 pairs of anchors, 2 medially close to the middle part of the footprint, that is close to the cartilage, and 2 knotless anchors laterally on the lateral part of the greater tuberosity. Now the sutures through the medial row are passed through the cuff, and these sutures are passed laterally over the cuff, and then they fix in through the knotless anchors onto the lateral part of the greater tuberosity. Here, the fixation is much more stronger, and at the same time, the compression on the rotator cuff is much more uniform. This shows higher contact pressures in biomechanical studies, and clinical studies, it shows higher healing rates compared to a single row repair. Now, when I'm doing a rotator cuff repair, I have 3 goals. Number 1, I would like to repair it anatomically. Number 2, I would like to have a repair which is tensionless. And number 3, I would like to have a strong repair wherein I can assure good healing of the cuff. At the same time, I can be assured to mobilize the patient as early as possible in the post-operative period. Now, to reduce a tear anatomically, I have to understand the pattern of the tear so that I can repair it properly. It is similar to a fracture pattern, where you know the fracture pattern, you can reduce the fracture pattern. Similarly, you understand the tear pattern, you reduce the tear pattern. Now, coming to a tensionless repair, we should mobilize the cuff properly, the cuff and the musculotendinous properly, so that the cuff can nicely reduce onto the footprint without much of tension. Because a repair done under a lot of tension has high failure rate. Now, coming to a strong repair, a transosseous or a transosseous equivalent repair will give a very good strength of the repair, and with which I can start mobilizing the patient very early in the post-operative period. Of course, in a passive mobilization, not an active mobilization. Usually, we don't do active mobilization before 6 weeks after a rotator cuff repair. Now, position, I prefer beach chair position, but it can be nicely done in a lateral position. Traction device, I use a simple pulley in a beach chair position, and people can use a hydraulic arm positioner or a lateral traction device can be used. Coming to portals, I use 4 portals, a posterior portal, a posterolateral portal, an anterolateral portal, and an anterior portal. And these portals will be used interchangeably as a viewing or a working portal depending on the area of the cuff I'm working on. And I use 1 or 2 accessory portals for the anchor insertion on the medial row. And these portals, if you observe carefully, they're very close to the lateral border of the acromion. Now, coming to the anatomic repair. Now, there are different tear patterns which we routinely see during a cuff tear. The commonest thing, what we call is a crescentic tear, wherein you hold the center of the tendon and pull it laterally, the tendon gets reduced onto the footprint. This is called a crescentic tear type of tear. Now, you have a L-shaped and reverse L-shaped tears, wherein one side of the tear or one leaf of the tear is more mobile than the opposite. So once you hold this mobile leaf of the tear and pull it in the opposite direction, it gets reduced. Now, once you reduce it, it creates a longitudinal line and a horizontal tear component. This longitudinal tear, what we do is that we put some side-to-side sutures, and once the longitudinal component is covered, it is repaired, this becomes like a crescentic tear, and then you can proceed with the traditional crescentic tear repair pattern. Now, coming to something called a U-shaped tear, which usually happens in chronic retracted tears, wherein when you hold the center of the tear tendon and pull it laterally, it won't come. But there is some mobility in the anteroposterior direction. So after doing a lot of releases, what we do is that we do some side-to-side sutures and convert this U into crescent, and this crescent can be repaired onto the footprint. Now, there are some examples of a crescent tear. If you see here, once you hold the center of the tendon and pull it laterally, it comes nicely and sits there. There's a crescentic tear. And then this is a reverse L-shaped tear, wherein the anterior leaf is more mobile and it can be pulled posteriorly. And now once you see this is the apex of the tear, and you put some side-to-side sutures in the longitudinal component, and this side-to-side sutures will convert it to a crescent shape. And this remaining crescentic tear can be repaired in a traditional manner. Now, this is what we commonly say a supraspinatus tear and supraspinatus and infraspinatus tear. We see here, this is a tear involving the supraspinatus and infraspinatus and is a retracted tear. I cannot reduce the tendon easily, and it's a delaminated tear. If you see, there are two laminae of the tendon. Now, once I know that I cannot reduce the tendon easily, what I have to do? I have to mobilize the musculotendinous units. The first thing I do is a bursectomy so that I can have better visualization of the musculotendinous units. Now, I do three releases. Number one, I release the cuff from the superior surface from the spine of the scapula. The anterior part is supraspinatus and posterior part of the infraspinatus. And then I release the cuff from the deep surface from the glenoid. So I release the posterior capsule and superior capsule. So I can mobilize the deeper surface of the tendon. And then I release the cuff from the coracoid, what we call as the coracohumeral ligament release. This mobilizes the anterior border of the supraspinatus nicely. Once I do these three releases, I check again for the reducibility of the tendon. Once I'm happy that the tendon is coming onto the footprint without much of tension, then I'm ready to repair the tendon. And here, what I do is that I prepare the greater tuberosity, gently decorticate with a burr to increase the chance of healing of the tendon. Now, once I'm ready to repair, I put two medial row anchors, one posteriorly and one anteriorly, close to the cartilage. This is the medial row. And to achieve this angle of insertion, we place the anchor close to the lateral border of the acromion. First of all, we check with the needle for the proper angle of insertion. And so this can be assisted by adducting the arm gently and with slight internal or external rotation. And once we're happy with the location, we'll make a small nick on the skin and pass the anchor close to the cartilage and fix the anchor in the medial row. Once you put these two rows of anchors, two medial row anchors, then we pass these switches from the medial anchors through the cuff. I usually use a Akipass kind of device, or you can use a clover hook kind of device, or you can use an anti-grade switcher pass like a scorpion. And once we pass these switches in a mattress fashion, you have 4 pairs of switches, and you can tie these switches in the medial row. Now, but the biomechanically speaking, tying all the switches in the medial row gives a stronger fixation. I tend not to strangulate the tendon. So what I do is that I tie 2 pairs and I leave 2 pairs without tying. Now, once we do this, after the medial row repair, this is how the tendon looks. And once the medial row is fixed nicely, then we start doing our lateral row fixation. Here, we take the sutures from the medial row, we crisscross the sutures. That means we take some from the anterior part of the tendon and some from the posterior part of the tendon. We crisscross the sutures and we load the sutures into the eyelet of the lateral row knotless anchor. We use knotless anchors here. So these sutures will be loaded into the eyelet of the lateral row anchor, and this anchor will be inserted onto the lateral part of the tuberosity, usually 1 to 1.5 centimeters below the footprint region. So here I'm putting my first anchor at the anterior lateral row anchor. There are different types of lateral row knotless anchors available in the market. And again, now I'm putting the second anchor posteriorly as a lateral row anchor. Now, once this is done, any minor uneven ends of the cuff can be managed with some additional sutures that are available in the lateral anchors. And this is the final repair. You see, the cuff is nicely reduced, sitting nicely on the footprint. And you can see the compression, it's sitting nicely. And I'm checking for the stability of the cuff here. You see, the cuff is stable. And I check from the interarticular surface. Here you see the cuff is sitting nicely close to the cartilage. That means the cuff has been compressed uniformly throughout the footprint. This is what we want to achieve by doing a transverse equivalent repair. A subscapular repair, again, is almost same with slightly different depending on the location. What we do is that to mobilize, we release the rotator tissue, and then we do a nice subcoracoid release to mobilize the upper border of subscapularis. And then we release behind the subscapularis from the anterior glenoid or the anterior capsule. And then once this is done, we mobilize the anterior surface of subscapularis from behind the conjoint tendon. Here you have to be careful because the axial nerve is in a close vicinity. And once the releases are done, we do a trial reduction. Once we know that reduction is good, we put 2 rows of anchors immediately close to the cartilage on the lesser tuberosity. If you see, already one anchor is inside. This is the second anchor that is going in on the superior part of the lesser tuberosity. And again, pass the sutures and tie knots similarly. And usually use a single lateral anchor for a subscap repair. Subscap, most of the times I do a single repair, especially when it is a combined lesion of supraspinal subscap. But occasionally I do a double repair for subscap when I have a come across as isolated subscap tear. So if you cannot repair it easily, what shall we do? A tensionless single repair is much better than a double repair done under tension. So it's better to switch to a single repair. Sometimes what we do is that we take out the cartilage, little bit of cartilage near the footprint. That means we shift the footprint slightly medially and repair the tendon into the newly middle-aged the new footprint without tension. Sometimes we use the long head of biceps to augment the repair. And sometimes we just do a partial repair. This works well in elderly individuals who are low demanding. And sometimes we do come across tendons which are not repairable. Then you go for the choices will be tendon transfers or superior capsule reconstruction, or in-space balloon or reverse shoulder replacement kind of thing, depending on the age and demands of the patient. Thank you all. Thank you very much.
Thank you, Chandra. It was a fantastic presentation. I'm sorry I joined a few minutes late. I had a call from the hospital. Chandra, just one question: that how much are you bothered about all these dog ears and bird beaks? I mean, I have realized that the scenarios in which you don't get any dog ear and any bird beak, significant bird beak is not very common. I mean, we do get once in a while bird beaks and dog ears, and I have stopped reducing them beyond a point. I feel that arthroscopy magnifies this too much. So do you really take them very seriously, or every attempt to reduce that, and every attempt, even if you see a small dog ear or a bird beak, you go ahead and reduce it, or you leave it?
No, I think unless it's really significant, it's not necessary for us to really put one more suture and fix it onto the bone. Can you hear me, Vivek?
Yeah, I can hear you.
So if you've seen, even in my video, I have reduced one part of the dog ear, but the anteriorly you can still see a small bump.
Correct.
I think we should not do too much of suturing and try to put too many sutures and try to compress it too much. I think single row is little less compression. I think double row we're putting too much of compression. I think with minor dog ears we can just leave it alone. Nothing much will happen. I think. Yeah.
I, in fact, try to do a little bit more anteriorly. I don't leave a bigger ones or unsupported area anteriorly. In posterior ones, small little ones, I don't, bother much, because I personally feel that majority of the tendon, the contraction, the supraspinatus power is important for the anterior third. So anterior third, anterior half, if there's an unsupported area, I would still go ahead and put some sutures, but posteriorly I have stopped, looking at them too critically. Nitin, what is your take? Yeah, sir. Yes, sir.
Vivek, you did a very valid point. Nowadays, what I'm trying to do is I'll put my anterior anchor, the medial anterior anchor, very anteriorly, so that it's very near to the anterior cable. So that's what that's a very valid point. So once that is done, then we got a peace of mind.
And second point, to Nitin. Nitin, when we are talking about these biceps, especially in the 50s, when we get these traumatic large tears in 50s, I'm 60 plus and all, usually in India, bulky arm, I just do the tenotomy and leave them. But 50s, thin arm, women, because now these days is a fashion of sleeveless, so they want to wear the sleeveless. So when it comes to the biceps tenodesis, do you do the biceps tenodesis separately, or you would just take a triple loaded anchor and use one of the, the limbs for tenodesing it? And do you do it in the groove or just under where the, it is crossing the joint?
So, good morning, everyone. Firstly, to answer your question, somebody in 50s, I always prefer to do a tenotomy. But moving further on to the tenodesis question, if I'm having to do a biceps tenodesis, I always do it in the groove itself using an anchor.
Okay.
But especially in a scenario where there is a rotator cuff tear, in 50s, I will explain to their patient. Honestly speaking, I think Popeye sign is a little bit of a over talked topic. I'll tell them about the Popeye sign, but I'm not getting many of them with Popeye sign, especially in the Indian population.
I actually, only in very thin individuals, whose arm can be really, thin. There are some people very thin arm, especially women. I'm a bit skeptical because if it happens in one, because one woman did come and, scratch me for a few months. And she said, see, doc, there's a little bit Popeye and I can't wear a sleeveless. She was very clear that that's the reason I have stopped wearing sleeveless. She said, sometimes I want to wear. So since then, I have been a bit cautious about thin armed women, especially men. It's okay. Men, probably sometimes they don't bother much. Yes, Chandra, what's your take on this?
Yeah, I'm a anatomy guy. Most of the times I do anatomy, and you know that where we will learn from that.
Europe is, a anatomy guy, so I'm somewhere in between. Dipti sir, you said you wanted.
Yeah, I always recently I'm actually doing mostly tendon to tendon repairs. You're doing the long head of biceps. I repair it onto the subscap. If I'm doing a subscap repair, I include the biceps into that. If I'm doing the supraspinatus, I include the supraspinatus with the biceps.
Okay.
And
No,
I do that whenever there is a problem with the pulley. If there is a problem with the anterior pulley and there is a partial subscap tear, then I tenodise it to the subscap. If there is a posterior pulley problem, then you have you put it to the supraspinatus.
So let's thank you, Chandra. It was a fantastic presentation. I again apologize for joining a minute late because I just got stuck in hospital. So I would invite Dr. Ram if he's around, so we can play the Ram's presentation.
Greetings to everyone. Thank you, Oasis and Dr. Deepdinandan Atla for the kind invitation for the meeting. I'm going to talk about open reduction and internal fixation of proximal femoral fractures. I run my own ortho specialty clinic at Heart of Chennai, and I'm affiliated to MGM Healthcare as Director, Institute of Shoulder, Elbow, Hand, and Sports Injuries. As far as the displaced 3 and 4 part fracture is concerned, these are the treatment options: a minimally invasive fixation, open reduction and plate fixation, intramedullary nailing, and prosthetic replacement. See this example of a 74-year-old gentleman had pinning elsewhere 1 year ago, and he presented at this stage to me after having developed a pin tract infection and stiffness and arthritis. So this percutaneous fixation has to be very carefully performed. Don't forget the 4 guiding principles: near anatomic reduction, stable fixation, preservation of blood supply, early active mobilization. All these are very much possible with the use of plating. And these are the various plates I have used the past few decades. We had experience with the Phylos plate. I started to use in 2002 in UK. We reviewed our first 102 patients. The average age at the time was 62 years. And this is my technique. Through a short deltopetric approach, do an indirect reduction of the head fragment to face the glenoid, and apply sutures at the musculotendinous interface of the rotator cuff to the tuberosities, reduce the fracture, and apply the locking plate, and tie the sutures to the suture holes of the locking plate. We have to be very careful in the placement of the plate location as regard to the height to avoid impingement of the acromion, and second, the location lateral to the bicipital groove. So this is after fixation with the locking plate, final reduction. So sticking to 3 principles: number 1, accurate anatomical reduction of the tuberosities supported by tension band sutures which are tied to a plate. And second, a good call cord reduction supported by a call cord screw. And third, not putting long screws. Do not treat shoulder as a hip. You don't need to chase the tip apex distance here. So you see the examples of a call cord screw placement. And additionally, if necessary, I use a lesser tuberosity fixation from anterior to posterior. Post-operative, I put them in shoulder sling and advise to start pendulum movements, assisted forward elevation up to 90 degrees starting from day 1, progress to full range of movement in the 2nd month, and muscle strengthening exercise in the 3rd month. So these are our results at the time. All fractures have healed with mean constant score of 79. So we concluded that it is a stable construct, maintained fixation till healing with no metalwork loosening or migration. We had 4 avian, 1 secondary fracture and 1 infection. This is an example of a 4-part fracture treated with Phylos plate, started to develop avascular necrosis, progressively became painful. The metalwork was removed and converted to resurfacing orthoplasty. This is the beauty of reconstructing the tuberosities, because you have a stable platform over which you could do a successful shoulder replacement should a need arise in the future. This is the patient treated with Phylos plate, fell down at 6 months after the index operation and sustained a periprosthetic fracture. This was treated conservatively. As you see, if you look at the various published literature, the locking plate complication is there, and the most important is a screw cutout. This is an example of a case, a 52-year-old patient, 1 year, 1 month post-ORIF presenting with this protruding screw. It's an example of a long screw following collapse of the femoral head, but it was left longer, so it caused damage in the glenoid. These things should be avoided. So I'll provide some technical tips. First and foremost is the reduction. You have to get the reduction first. Use sutures. Do not manhandle the tuberosity fragments. Provisionally fixed with wires. Then you apply the plate. Positioning is important. Rarely I use the plate as a reduction tool only to achieve the calcar reduction. Otherwise, the plate is applied after reduction only. Do not put long screws. Stay away from the articular margin 5 to 10 millimeter because it is a sphere. The locking plate can cross the femoral head and may not be obvious in the AP X-rays. Do not drill until the subchondral bone. Same way, the plate positioning is important because in a fixed angle construct, the locking screw follow a dictated angle. So you have to decide what is the best position to have the calcar screw. And most important, do a dynamic screening at the end. It is very difficult to get AP lateral static X-ray picture. So do a dynamic screening. If in doubt, replace or remove the suspected screw. You can augment the fixation by using a small plate to fix the lesser tuberosity if it is a larger fragment or comminuted, or with the synthetic bone graft or iliac crest bone graft if there is a suspected osteoporosis, if you need a metaphyseal support, or occasionally fibular graft if it is for a chronic non-union or failed osteosynthesis. So there are some new development which I will touch base. This is a variable angle titanium locking plate. The locking is done by bush locking, so it could have up to 40 to 60 degrees of a variable angle. The advantage of this is that your screw direction is not dictated by the plate location. So you could put the locking screw in a good place of the humeral head where you like to purchase. The new development is also the biomaterial used in the plating. This is the carbon fiber reinforced PEEK plate. This has got torsional strength, mechanical strength that equivalent to that of cortical bone. It provides a multi-directional locking system of 24 degrees and biologically inert and radiolucent. We had a good experience of using this plate in the last 2.5 years. We have done close to over 80 patients. The first 62 patients were followed up, were operated between November 2016 to October 2019. 2 patients lost to follow-up, so we have 60 patients available for review. The mean follow-up was 24 months. The mean age was 55 years. The age distribution is as shown, but note the preponderance of the age group between 50 to 60 compared to older age group in the West. This is the classification of the fracture configuration. 16 2-part, 15 3-part, and 29 4-part fractures. This is the operative technique. It's similar to what I have been using with the Phylos plate. Same tension band sutures over the rotator cuff and secured to the plate. This is after fixation. You could do a view of the proximal humerus, AP, lateral, dynamic, with much clear resolution compared to Phylos titanium plate. Our results show that all fractures have healed with a mean time to union of 14 weeks. There were no malunion or non-union observed. Is an example of a 42-year-old after road traffic accident with displaced to two-part fracture. This is after fixation with a peak locking plate. Healed very well with good outcome at 3 months follow-up. It's an example of a 38-year-old after road traffic accident sustaining four-part fracture. You see the component of the greater lesser tuberosities and the significance of the displacement. This is after fixation with the peak plate, and that is at 6 months follow-up, near normal movement, inflection, internal, external rotation together. Our results show that the average flexion was 160 degrees, abduction was 154 degrees, and external rotation was 40 degrees. Internal rotation was up to 7.5 points. The mean constant score was 82, and that shows the components result. This is the constant score distribution of the entire group, most of them scoring above 70. As per the Oxford score, there were 36 excellent and 24 good results. All patients were satisfied with the outcome. There was no varus collapse. There was no implant breakage. No screw penetration observed in this series of 60 patients. There were one impingement, one hematoma. I did not recommend routine removal of the plate. It was removed in 3 patients, 1 for impingement, 2 patients for their request. So overall, 5% patients had plate removed. The removal was easy. So looking at the literature, biomechanical studies show fixation strength of 191 Newton with the P plate compared to 286 with the titanium plate. So it is an ideal implant for metaphyseal fracture, not for diaphyseal fracture though. So the same group published a clinical series showing significantly better constant score and Oxford shoulder score with less loss of reduction and varus collapse. Another series of 21 patients show functional outcome similar to both groups, but the peak plate was observed to have less screw cutout and loss of reduction. Again, another series of 42 patients showed low rate of GT absorption than metal. A multi-center study shows result as reliable as a titanium plate, as well as a recent randomized controlled trial at 6 months outcome showing comparable with titanium plate. So we have clear advantages here with the use of peak plate. The modulus of elasticity is closer to the bone, so less stress shielding. Is a radiolucent plate, so allows better intraoperative reduction and also monitor healing during the follow-up. It's biocompatible, less scar tissue, no cold welding, so it is easy to remove should the need arise in the follow-up. And is also MRI compatible. So to summarize, I displaced the 3- and 4-part fracture. Fixation with locking plate had been my gold standard, although we are aware that various techniques are available to treat these complex fractures. But the key principles are to have a stable fixation of conquer and fibrosity, use of tension band sutures in the rotator cuff interface, and have optimum screw trajectory. Bone grafting, if indicated. The key is also to early mobilize the fracture to get the best outcome, that is range of movement of the shoulder joint. In our experience, peak plate provides reliable fixation and has a lot of advantages. Thank you for listening.
Is Ram there? Because I called him. He said he should log in. Ram, are you around? Okay, and Dr. Pratap, and unmute yourself. Unmute yourself, sir.
Yes.
Sir, in 2-part, maybe 3-part, even up to 4, these plate fixations are fantastic, no problem. But what about the dislocation? Do you continue to treat these fracture dislocations in the similar fashion, or you have some other protocol when it comes to fracture dislocations?
Okay. Yeah, definitely. Fracture dislocation means, especially in an elderly patient, that means cuff is also going to be damaged. So I need to address the cuff. It's not only the bony part; it's the soft tissue part as well, especially the supraspinatus, infraspinatus, and the often forgotten is the scapularis. So we need to take time meticulously to repair that as well. Now, fortunately, most of these modern plates has got locking plates has got this separate slots for repairing it, and you need to take time. Okay. whatever looks on the X-ray doesn't translate into function if you don't repair it.
So what about in the young adults? So young adults, you treat in the same fashion, you would save the head, and if at all, it's like, I'll wait for the avian, unless and until I'm not including those split heads and very badly comminuted heads. A simple big chunk of the head with a metaphyseal beak, you would still treat it exactly in the same fashion.
Definitely, I will treat it in the same fashion, but I will make sure that there is no virus deformity there. And if needed, I will put an intramedullary small strut graft so that it can be reconstructed.
Deepti, sir.
Yeah.
Do you believe, because I often do that, I don't know how many people will agree, because often it happens this head now, there's very little control. Unless there is one tuberosity attached to the head, it's not easy to control the head. It continues to go either retroversion or sometimes in varus. So I don't hesitate passing one K wire and holding it exactly the way I want through glenoid. And once my, some provisional fixation has happened, then I immediately remove it. And yes, meanwhile, I ensure that I don't move anything much. So do you recommend this? Do you do that? Because despite all the expertise and good experience, I still sometimes struggle. The head keeps wobbling. It just goes in varus.
Yeah.
And varus head is like a day one failure. So you have to ensure that, you hold it in the desirable position of, subtle valgus. If it goes in subtle valgus, I'm still okay, but definitely not in varus.
Yes, that's a very good technique, Vivek, and it's a very valid point. Especially the varus ones, if they are elderly, they tend to fail very badly. And
Yes.
even though your fixation is brilliant at the first go, later on you see that they collapse and they cut out. Holding it with a wire is a good idea, but the only problem I have when you do that is that you can't actually reduce the GT. That is the biggest issue, because the wire keeps coming in the way.
So what I do is I kind of think where this whole reduction won't come in between. So pass it from a non-fixable area. It goes sometimes via the cuff or via something where the plate or screw, nothing will come. So my only question was, do you people are okay, recommend that it's okay once in a while to fix it? If you
Yes,
have
it is okay once in a while to do that, because it is good to have a good positioned head over your tuberosity. So if that is not there, then it's not going to unite properly. So it's no problem with that.
Yes. And second is, Ram had put up this. Often it is otherwise. In fact, when you put up Ram is there. Ram has got 100 years. Fantastic. I just named you Ram. Okay. So Ram, good. I'll direct this question to you.
Yes.
When you said you don't use the plate for reduction, the shaft to the, the head. In fact, it's most of the time otherwise, Ram. The shaft is often a bit lateral to the head. And in fact, when you put the first reduction screw, it tends to further lateralize. So I'm a bit more skeptical. I don't tighten it full. So you have any tips and pearls for that?
See, the reason why I put that slide point is this is a locking plate. So a cortical plate, we could use that, a normal cortical plate, to draw the fragments together. But here in a proximal humerus, you have to reduce the fracture first, have some wires, provisional fixation, then just apply the plate. That's what we should be doing. The only occasion where you do that is only when there is a medialization of the shaft. I use a non-locking screw in the distal oblong hole to draw to reduce the Colcar alignment. Apart from that one particular indication, in my practice, I never use the plate as a reduction tool at all.
Yeah. True. Okay. The other question which I actually directed to Dr. Pratap. So, the typical, 3-part and 4-part, you go with the standard principles, what you described. Do you take the fracture dislocations, in a slightly different fashion, comparing the two groups, young adults and the elderly? What is the difference in approach, planning and approach when there's a fracture dislocation, not just the mere fracture?
Okay. Yeah, I just want to make sure
Pratap sir, I want Ram to answer because you already answered.
Yes.
So I'll just direct him again.
See, when there is a fracture dislocation in a young patient, my aim is to get the fracture reduced, even though it is completely displaced like a loose fragment head in the axilla or anteriorly. My aim is to reduce it, fix it, don't worry about the vascularity. And osteosynthesis is my aim. Whereas the same thing happens in an elderly patient, I would have a different threshold for fixing because of the instability, aging, and one-shot operation you want to do. My inclination is towards replacement. That is one sort of fundamental difference between the age group.
Okay.
technical tips in reducing in a young patient.
So I'll interrupt for 1 second. I'll say, so when you are operating a fracture dislocation in elderly, always keep the replacement processes ready. If
Yes.
so, because you're also worried about the cuff, always keep the rivers in hand.
Yes.
Because you don't know what is the finding, especially on table. You know, what if there's a massive cuff tear which was never picked up?
Yeah, absolutely. But when you're in a younger patient, we're not expecting the cuff problem. Even if it is a loose fragment, it can still, the head fragment can survive. A part of avascular necrosis is also well adjusted in the shoulder in the long run. So you aim to synthesis only. Technical tip wise, there is I usually go by anterior deltobuccal approach. And what happens is that in a fracture dislocation scenario, when it is anterior, sometimes the long head, most of the time, the long head of biceps is stuck across the fracture. So that you have to do a tenotomy, release the long head of biceps, reduce the head fragment, and restore the, as we discussed before, greater lesser tuberosity fixation. And never put long screws in that scenario, because we are expecting some sort of avascular necrosis to happen in a complete fracture dislocation. So always short screws of the sphere. And then you do a tenodesis of the biceps, which you have taken cut before in the approach.
Fantastic. No, your talk was remarkable. So we had only 1 or 2 of these doubts, you know, regarding the fracture dislocation. That is the standard. Fantastic. Thank you, Ram, for joining.
Thank you.
Thank you. Yeah, Deepti, you are next.
Yes, I think we'll have the next talk, which is on distal humerus fracture fixation, please. And give patient a good result. So the aim of this talk is to show you the technique of using the para-olecranon approach for distal humerus fracture fixation, and to understand the anatomy and the principles of fixation of this fracture. Looking at the anatomy, distal humerus is a 2-pillar construct with an articular bridge at the end of the bone, and this articular bridge is placed anterior to the shaft of the humerus. Most of the approaches of the distal humerus are through posterior approach, so it's often not easy to visualize the whole of the articular surface. And this articulates with the radius and ulna to form a very complex hinge joint. And contrary to the belief that it's a non-weight bearing joint, there's substantial forces going across the elbow joint. So it is of paramount importance to have a good construct on the distal humerus for the functioning of the elbow. If you look at the historical literature on operative and non-operative treatment of distal humerus fractures, operative treatment seems to be providing better outcomes, and non-operative treatment is 4 times likely to have a delayed union or a pretty bad result from the treatment. So the gold standard at the moment is to fix these fractures early and mobilize them to regain near normal function in the elbow. The principles are to restore the articular surface, have 2 column fixations to restore the columns of the distal humerus, and to have a good subchondral strut to support the multiple fragments of the articular surface. And these struts are fixed onto the column so that we have a triangular construct, like so. Having these struts in the subchondral area is the most important part, and these should be fixed onto the plate to give you a triangular construct on which the elbow joint can work effectively. If you look at the distal humerus, it's very important to recognize the various fracture patterns. If you see that majority of the fractures happen in the capitellar area, which is comminuted. Most of the time, the trochlear area is intact, and these are the ones which, with an intact trochlea, which can be used, where we can use a paratriceps approach. Recognizing the fracture patterns is very important to determine what type of approach we use, and a 3D CT scan is very, very useful to help in surgical planning as well as to give them good outcome with open reduction internal fixation. The current fixation options are either a contoured LCP or a pre-contoured locking plates. The pre-contoured locking plates now are giving very good results, and recently even variable angle fixation devices with variability in the screw fixations onto the plate have been introduced, but they're a bit more expensive. There is always a debate about dorsal or a 90-90 plating. Either way, if you have a good two-column fixation with interlocking screw subchondral struts, you will get a good outcome. We have a hybrid construct in India where we can use the lateral plate with an outrigger. This outrigger helps you get the subchondral struts and interlock with the medial subchondral strut. So we provide a good triangular construct and distal humerus. The double plating, the main principles are the plates need to be stiff, the two columns need to have support, at least 2 to 3 cortices from each side to be engaged. Locking plate for a stable construct so that the forces are spread from the screw onto the plate rather than relying on the bone itself. The pre-contoured plates or the contour plates should be fitting the bone well so that the plates are not prominent. As you know, the distal humerus is a very subcutaneous bone. The other commandments are that all screws should pass through the plate. There should not be a screw which is independent, like we used to do in the traditional fixations. Long locking screws on the distal fragments are needed, and these should be interlocking on the distal part so that they provide a good support for the cartilage. The approach is mostly posterior, and you can either do a tricep split approach or you could do a tricep sparing approach like so, where the tendon is attached to the olecranon. Here the tendon is split and is exposing the distal humerus. You can also do Brian Murray type of approach where it is completely detached from the olecranon and the tip of the olecranon is excised to show the distal articular surface. The disadvantage of this is that you cannot see the whole of the anterior part of the articular surface. So a more extensile approach is sometimes needed. A tongue approach is a traditional approach we have been used, and any old fractures with a contracture on the triceps would benefit from this approach, as we can do a VY-plasty of the triceps. But a better approach would be olecranon osteotomy, especially if there is a loss of the intertrochlear groove cartilage and we need to get a good alignment or visualization of the whole of the articular surface. My preferred approach is to go for a paratriceps approach to start with and then progress on to olecranon osteotomy if I cannot visualize the articular surface. So getting the configuration of the fracture is important before we start. So this is a paratriceps approach I'm going to demonstrate. This is a gentleman, 32-year-old, fell off a bike and injured his elbow. This is the anterior view. You can see that the fracture, the proximal fragment is displaced anteriorly. The posterior fragments are here. There is comminution of the lateral column of the distal humerus, that is the capitellum. The posteromedial approach, you can see there is an articular step there. This is one single fragment, so these can be managed with the paratriceps approach. The medial side is not comminuted, so we can start fixing from the medial side. This is a full thickness flap of the skin. You can see we don't put any retractors on, except for a skin hook, and you should gently handle these tissues. Incise the lateral border of the ulnar nerve with a flap so that we mobilize the ulnar nerve right up to the FCU, up to the intramuscular septum superiorly. The ulnar nerve should be mobile like so. So we can replace it after fixation. Expose the distal humeral shaft and then go on to expose the medial epicondyle, because the medial plate will be coming onto the medial edge of the humerus. So we should have good exposure to the whole of the medial column of the distal humerus. Be careful not to cut the medial collateral ligament, which is just there, and freshen the fracture edges to get a good definition of the interdigitation at the fracture site. The lateral approach, incise the aponeurosis, split the anconeus, and then expose the shaft, remove all the excessive hematoma to define the fracture surfaces, and remove all the
loose bits of bone and the hematoma with a forceps. I don't use a curette because it changes the architecture of the fracture surface itself. Put a stay suture on the anconeus and the capsule, so this will be very useful for retracting this flap and visualize the articular surface. That is the lateral epicondyle being exposed. Again, don't cut the lateral collateral ligament, which is just distal to the tip of the lateral epicondyle. And then progress on to incise the capsule and expose the capitellar articular surface. You can see that comminuted fragments there. Don't disturb those. Now this suture acts as a traction and you can visualize the lateral column of the articular surface. So we'll go on to the fixation in the next video. In the fixation, you should first determine which side we're going to fix. Here we had a big lateral medial fragment, so we're going to fix that first. So reduce the fracture onto the shaft, medial condylar fracture, and then pass one stabilizing K-wire. And on the lateral side, we know it is comminuted, so you should be having a joystick to hold the articular surface and reduce the fracture fragments, making sure the alignment of the articular surface is well maintained. And sometimes the olecranon helps as a scaffold on which you can build the articular surface. Once you use the joystick on the articular surface, reduce the fracture. Again, stabilize it with an intercondylar wire first. There, then followed by fixation of the main fragment of the lateral part of the distal humerus. That's the lateral pillar. That is the lateral pillar fixed and stabilized. And now we put a wire to hold these fragments together and check it under image intensifier. Then place the lateral plate and make sure that the outrigger screw is going into the articular surface and not going into the joint itself. That's the screw going in. You should also make sure that the end of this plate is not very close to the capsule, otherwise you'll get impingement of the capitellum onto this plate. This is the capitellar screws holding the capitellum itself. And you can see that it's not impinging after the plate has been fixed. Check under image intensifier, make sure these screws are not long. And this is the medial side plate going onto the medial edge of the humerus and the medial epicondyle. And once these screws are placed, you tighten the proximal screw so you get a compression. And then close the lateral side, progress on to the medial side, check the nerve is going on easily without any friction, and that's the closure. That's the postoperative images, confirming that there is interdigitation and good alignment of the fracture. And this is the postoperative regime. This is day one post-op, and the patient starts mobilizing these elbows straight away. This is the only exercise they go for, and they don't go for any formal physiotherapy. Thank you very much.
Thank you, Deepthi boss. Fantastic. So do you, I mean, okay, you're basically you wanted to show your tricipital approach, which I usually don't do if I find too much of, articular, the fracture lines running into the joint. So when do you actually decide, looking at the CT scan, you say, this is my, pre-decided, this is tricipital, and this is where I will straight away go ahead for the transolecranon, and I will not struggle. It's like, very categorical division. Yeah, like let's say there's a one fracture line only going towards the either towards more capitulum or more trochlea, because with that paratricipital, you can retract the triceps on the either side. So when is that when you preoperatively decide?
So preoperatively, the CT scan is very important for me. And when I see that there is the trochlea is intact and there is no coronal split of the trochlea, I know that I can manage this paratriceps approach.
Okay, so
That is the
trochlea
most
being
important
intact
part, because
is
the
the key.
capitellar part you can always see very easily.
So fracture line being more towards the capitulum side, you decide preoperatively that I can manage this one as a paratricipital.
Paratricipital, yes.
But if it goes towards more towards the trochlea, or there are one or two more lines, then you say, okay, straight away go ahead with the
Osteotomy.
Okay.
But you can always do the paratriceps, look inside, and if you feel the fragments are not aligning properly, then go on to an osteotomy. That's much more easier. Then at least you're avoiding an osteotomy. You can.
And how often I saw you using the image? How often you use the image in between? Do you use it very frequently or only after one kind of tentative fixation?
So only after the tentative fixation, because everything is open, you can see everything. So you start your image intensifier only after my provisional K wires have gone in.
Okay, because I often always find it, because somewhere in the lateral position, it has to come from side. It disturbs the whole, ecosystem. So
The position I have is that the arm is never changed. Only the C arm rotates around the arm.
And the second question is, do you always do the anterior transposition of ulnar nerve?
No, I don't do it at all actually. Only
Okay.
rarely I had to do it because there's a lot of tension on the metalwork. I had to do it, but otherwise I don't
So you
have
just
to do
put
it.
it there only, straight away back.
Yes.
Because I saw
Yes.
you taking a slip of a tissue. It's like under the the ulnar nerve.
There is always a sheet of tissue which is just under the nerve, so you should lift it with the sheet. So it's very easy to put it back, and the nerve always should have a gliding surface. We always talk about fracture fixations and everything else, but we never talk about tethering of the nerve. Tethering of the nerve is the most important reason why they have dissatisfied results later.
So, there are situations where you would have put the medial column plate medially, and there are sometimes you put it, just under the ulnar nerve. So even if it is under the ulnar nerve, you don't transpose it?
See, the configuration I showed you is the one I used all the time, and I don't put the plate posteriorly on the medial side. I always put it on the medial side.
Always on the medial side. Fair enough. Okay. All right. Okay. Because there are some plates which are actually contoured for posterior-medial.
Yes, but I don't use them.
You
Because
always
the
use it on.
configuration of the fracture there is always in, there are 2-3 fragments going out this way. So you need a buttress rather than a support at the back.
Ram, your views?
Yeah, I agree with that. I don't routinely do ulnar nerve transposition. I think you have to be extremely careful in putting that posteromedial plate. If you do a column plate on the medial side, then the ulnar nerve is not an issue because it just goes behind.
Correct.
And as you said, if you have the sleeve of tissue, it will protect it.
Absolutely.
So no need to do that. But otherwise, you have to be careful if you are putting posteromedial plate.
Because that was the traditional teaching. Every elbow
Yes.
surgery, especially those intercondylar, you have to do the anterior transposition, and that you always mention in your OT notes that you have done it.
That is the most important bit. for the somebody, if you want to do something in the future. Second thing, I think you were asking about a paratricipital approach. If
Yes.
it is a relatively simple intercondylar fracture, you could approach it paratricipital. And the worst case scenario, if you really want to have an access, you could connect and do a olecranon osteotomy as well.
Correct. Yeah.
Along with that, without damaging.
Sometimes you have a very categorical division. Yes, there is a gray area where you can always do. So you say, okay, this I can do paratricipital.
Yes.
This let's not struggle. Let's straight away do the osteotomy.
Exactly.
Yeah. Okay, fantastic, Deepthi.
Thank you very much.
Who is next in line? Chirag?
I think it is, it is Chirag.
Chirag.
No, it is Karthik. No, it's Karthik.
Karthik, huh? Okay, because Chirag is also here, stiff cough. Okay, fine.
No, that is the discussion part. That is not the video demonstration. So in videos, we have only latter J and then AC joined by Dr. Nitin.
Okay.
So next one is Dr. Karthik Selvarajan showing us about latter J procedure.
Okay, fine. Okay, right, go ahead.
At the outset, I would like to thank the organizing committee of OASIS-Con for having given this wonderful opportunity to be part of this program. My job is here to present a video of the Latarjet procedure. I'm just going to quickly touch down a few facts about Latarjet. So we know that we need both mobility and stability in an instability operation in the shoulder. And for the Indian scenario where there are players with poor financial background needing a very stable shoulder and a single short surgery, and also manual laborers who can't take too much time off work, this operation is actually a wonderful surgery for them. Now the indications is to salvage the primary operation. Latage, is it a dangerous operation? Is there a lot of complications like the Americans claim? Or if it's such a good operation, should we not be doing it for everyone like the French? So that these are the questions. I'll just quickly answer them. These are the indications for us for Latage. Any patient who has a glenoid index less than 0.8, and irrespective of the glenoid index, if the patient has got high functional demand like professional contact athlete or a manual laborer, then we still go for a Latage operation. So these are the three groups of patients on whom we perform the surgery. And this surgery, beyond doubt, is a very safe operation. All these studies indicate that the long-term complications of arthropathy are comparable to Bankart. The short-term complications are not that much. It's 5%, and most of them are negligible. They don't require any reoperation. So it's not a dangerous surgery. And compared to an arthroscopic Bankart, the coracoid bone block procedure actually is very, very successful. The recurrence rate is very less. The range of motion is good as compared to doing a remplissage along with Bankart. The extenotation is preserved. So it's a superior operation compared to Bankart, especially in young elite athletes, and also in bone loss situation. Even if there is a 10% bone loss, I think this operation is a good operation. So any patient, we think about the mechanism. The mechanism basically is both the bone block and the capsular sling effect. And in fact, the most important thing is this conjoint tendon actually tensioning the inferior subscap, making it act like a hammock. That's the most important thing. We do the classic European Walsh technique. We don't perform the congruent arc because in our study we found that the congruent arc is not possible in most of the Indian coracoids, as our coracoids are little small compared to the Western population. Now, perfecting the screw placement, everything in Latage is about screw placement. So if you have to get success in this operation, you have to be very perfect in your screw placement. That's the method we use actually. So we measure the coracoid dimensions with a caliper. Once we make the inferior drill hole, we actually measure the distance between the lateral aspect of the bone and the hole. And we also measure the glenoid neck and then make the hole appropriately. It's usually about 6 mm or 7 mm. We are usually very close to an mm whenever we do this. And once we do this, we always get a flush graft. There's no doubt about this. So we got about 100% acceptable placements. We did a CT scan on all the first 24 patients on whom we did this. And we found that the graft placement was accurate with this method. It's definitely advantageous compared to using a jig because you don't need to put both the screws in the same direction. You can actually alter the direction of screws. And most of the patients may not be a suitable candidate for congruent arc. So you end up doing this out of an operation. Perfect. You can use a headless screw if you want, but we always nowadays use headed screws. We use some bio screws as well in between. And Latage is a very good operation as a revision operation as well. And that's the sort of picture you get in the pre or in the post-op. If you get a CT scan, you can see that's the wonderful healing even in patients who have reasonably good glenoid. Without much glenoid bone loss, you still get good healing of the coracoid graft. So 146 Latage, 2 years follow-up. One transient infraspinatus atrophy, but that actually recovered in 3 months' time. So if you get a hard worker, if you get a contact athlete, if you get patients with severe bone loss, or if it's a revision procedure, then probably you should think about Latage operation. Let's quickly go to the technique. So this is the position of the patient. If you can see, and that's the skin incision. It's an axillary crease incision. There's a small incision. This is slightly bigger for demo purposes. Once the incision is made, you can see that the deltopectoral interval is identified. Once the deltopectoral interval is identified, the cephalic vein is protected. It's usually taken lateral. Once the cephalic vein is identified, the deltopectoral interval is separated, and then you can see the CA ligament coming into view. That's the tip of the coracoid. That's the CA ligament. That's the falx. That structure is basically the falx connecting the conjoint tendon to the CA ligament. So I'm just going to release it a little bit so that you can get a good idea of the lateral aspect of the conjoint tendon. Now, once that's released, you can see the CA ligament coming into. That's the CA ligament, beautifully seen. And you just use a carb or a periosteum just to make sure that separated from the CHL underneath. You got the coracohumeral ligament just underneath the CAL there. So once that's all separate, you actually have a Homan put on the base of the coracoid. So there is Homan at the base of the coracoid exposing it for you. You actually get the coracoid, the deltoid artery just crossing the tip of the coracoid, and you have to cauterize them because they will actually bleed torrentially if you don't cauterize them. The next step is the release of the pec minor. So that's the medial aspect. You actually release the pec minor tendon. Once the pec minor tendon is released, your coracoid is ready for harvesting. Sometimes I just put a gauze piece underneath there to make space. You measure the coracoid, you need about 20 to 22 mm of coracoid. So here we got a good length of coracoid, almost 24. So I just mark it with a cautery tip there from the area where you have to harvest it. And I usually use just a curved osteotome and a 1-inch curved osteotome for osteotomy. Haven't used saw in the last so many cases. It's very simple and easy. You don't need to struggle at all. That's it. That's the movement you need to do. There is a Homan at the back. You just lever it a little bit and then use a sharp osteotome. And it's not very difficult at all to do the osteotomy. You don't need a 90-degree saw or anything like that. So this is real time. So once the osteotomy is done, just gently lever it off, and that's it. So next step is preparation of the coracoid graft. So once you get the coracoid graft, you can use either a sponge holder or a coracoid holder for this purpose, and just prepare it. Mark the screw entry. Once you mark the screw entry, you pre-drill it. Once you pre-drill it, measure it. So I use a caliper routinely to measure the dimensions of the coracoid. Once the dimensions are measured, the inter-screw distance, the distance between the screw and the lateral border of the coracoid, everything are measured. Once that is measured, you know at what distance you have to make the drill hole on the glenoid. So once that is done, these are the various measurements you make. The next step is subscap split. I usually split the subscap in the middle, upper half and middle half. Some say that it can restrict external, but I haven't seen that in my cases. Going in the lower third and so that's the adduction and external to actually expose the subscap properly to you. So once you adduct and externally rotate, you can see the subscap in full, and that's the split you make in the subscap. Once you make the split in the subscap, you just have to split the muscle. You don't need to actually split the tendon at all. I usually put a Gelpi in so that the Gelpi helps the subscap to be spread nicely. You take a bite in the white capsule, just see just underneath the subscap. That's the vertical capsulotomy, just done just medial to the glenoid neck. So it's just as medially as possible, because you get a lot of capsular tissue for repair then, as if you go medially. Once the capsulotomy is done, then you insert the humeral head retractor. Once the humeral head retractor is in place, the glenoid neck just gets exposed like that. We prepare the glenoid neck with burr. Once the glenoid neck is nicely prepared, then you do the drill holes. So that's the drill. Oh, that's the. Just go back a little bit. So I just make the drill hole. Once I mark it with the cautery and then I measure it with a scale. I know that it's 6 mm in this case. So then I just drill it with a 2.5 solid drill bit, and then insert the guide wire through the pre-drilled coracoid and through the hole made in the glenoid, and then I insert my screw. Once the first screw goes in, you can actually use your finger as a guide to manipulate it and make sure that it is flush with the glenoid. Once that is done, you don't completely tighten it. Then you put your second guide wire in place. And once the guide wire is in place, then you can use a cannulated drill bit to drill the glenoid through that. And once that is done, you get the next screw in place as well. So you recheck, keep checking for any overhang, and you can rotate it slightly if you want after the first screw is in, and make sure that there is no overhang at all. In spite of it, if there is overhang, you can use a burr on the lateral aspect to actually burr off the bone, but then you have to take off the CA ligament in that case. So once the drilling is done, the next screw goes in. It's just normal, simple cantilevered cancellous screws. The classic European Lataje, you don't need to repair the labrum with an anchor. The capsule is put back with the CA ligament stump. So that's the capsule going on to the CA ligament stump. That's the bite. Going on to the CA ligament stump there. That's the repair. That's the subscap split, and that's the conjoint tendon coming out of the subscap split, as you can see that very well. And that's the surgery. So it's actually a straightforward operation. The skin is closed subcuticularly, and a sling is given for comfort. Post-operatively, 3 weeks of sling immobilization. Sling is taken off for shower. Sling is taken off for wearing a shirt and other things. So once that's all done, after 3 weeks, active vested range, and by 8 weeks, we start strengthening. And by 4 to 6 months, usually we get a CT scan at 3 to 4 months time, and then let the patient go back to his work or sport if it's a manual work, or if it's an overhead sport. Usually return to sports very early with Lataje. So why don't you Lataje in all patients? I think everyone should read this paper by Jill Walsh himself, Contraindications and Complications. There are certain complications and there are certain contraindications for Lataje. So it's not a panacea. It's not a surgery we should offer for everyone. So take home is it's a cost-effective solution for shoulder instability. It's non-anatomical, but long-term concerns are not much. Good surgical technique needed to avoid complications. Congruent art may not be suitable for Indian patients. Doing it arthroscopically probably is costly and still dangerous. So let's let the technique evolve, then we'll probably think about it. Now, thank you very much for patiently listening to my talk.
Thank you, Karthik, for the elegant demonstration of the Lataje technique. I think it was quite nice, quite informative. So I'll open some questions to the others, what Karthik has already told. Apart from what is very standard, the standard is okay, more than 20 to 25% of the glenoid bone loss. There is hardly no debate less than bony cell. But I am talking about how many of you, the panelists, have shifted now to doing the Latajes, even in cases where, let's say, there's a 8% bone loss, 10% bone loss, but the person is a professional athlete or a wrestler or a manual laborer. A manual laborer needs to 8% bone loss, 10% bone loss, and let's say medium-sized hill sacks. So is it still prudent to Ram, can you for a while mute?
Yes.
Yeah.
Sorry, I mean,
So how many of you will straight away jump the gun and will say, no way, laborer, professional athlete, I will do the the contact sports, I will do the Lataje irrespective of bone loss. That's the Pandora box I want to open up. So I'll start with Deepti.
See, this Lataje thing keeps on going, but I think I only do it for bone loss. I don't do it otherwise.
Bone loss is, what is your cutoff?
20%.
20%. So let's say it is 15%. He's a wrestler, professional athlete, manual laborer. You will still give him a chance with bank cut and remplissage, plus minus?
It depends. If they're going into contact sports like a wrestler, I will probably go for a Lataje. But that little variation is always there. There is no black and white in this thing.
Non-contact
sports, always take into consideration what they do. So
non-contact sports.
Non-contact sports, I will still go for a arthroscopic bank cut.
Okay. Pratap, what is your take?
I completely agree with what Deepti said. I got a very high threshold for Lataje. Still, my percentage is 5% or so.
Okay.
Yes.
Yes.
Usual cutoff is 20%. But I think if the person is like a contact player, like a kabaddi player in India, or heavy manual laborer, or there is a case of revision as well. Somebody had an arthroscopic failed procedure, but moderate bone loss, around 10-15%. I would go for a primary Lataje.
Okay.
I think our indications are slightly changing.
Chandra, Nitin, quickly the bite. Do you differ? Like I almost go with the same what Deepti said, and maybe because I also have a little higher threshold. I'll say with Pratap that I don't do it very often. I would do only when when the bone loss is more than 20, or he's a very heavy contact sports, where there's maybe I will take up the Letaje. Otherwise, I'll still believe in a very good Bankart repair and repair. Give a natural chance, fails, okay, I am an always pro for the, the Letaje. Chandra, what's your take?
Yeah, see, my threshold to do a Letaje in a contact sports person is very low.
Okay.
When it's 5 to 10% also, probably I prefer to do a Letaje rather than do a Bankart. And usually I don't want to do a Bankart with repulsors in these kind of people.
Okay.
If I want to give a very stable shoulder, especially even with the bipolar lesion, you know that Letaje works very well.
Okay.
I prefer to do a Letaje rather than do a Bankart with repulsors.
Okay.
Occasionally, it's like a first or second dislocation with no bony lesion at all, only a labral tear, and a simple Bankart repair is sufficient. I go for a Bankart repair in these kind of patients. Otherwise, if it's a wrestler, kabaddi player, or a kind of any contact sport, I would prefer to go for a lateral straight away.
Okay.
So is very low.
You're almost like, what Karthik is, Karthik's philosophy. Any difference with philosophy?
Absolutely no difference. I agree completely with everybody. To be practically speaking, majority of the patients are not contact sports players. Majority are regular fell off the bike, dislocators. So for all those things, for all those population, up to 20%, I'll still go for arthroscopic with counseling. That Letaje is always a procedure if required.
Okay, fine. Karthik.
Yes, Dr. Vivek. Yes.
Yes, Karthik. Thank you. Karthik, few tips. Number one, Ram sir, just mute your mic.
Sorry?
Ram sir, mute your mic. Your indicator is making a buzz.
Okay.
Thank you for being with us.
I hope he's not driving.
Yeah, I think he's in car. So Karthik, the question number one is how often you take this, CHL, correct? Sorry, the CA ligament. CA ligament. To take the bite, is it a routine procedure? Because it has to be done right at the outset. After that you can't come back. Or you take your call. You say, okay, this patient has dislocated 100 times, so he will have possibly a poor capsule. So in this case, I will take. So is it routine, not routine?
No, taking the CAL is a routine. 1 centimeter stump of CAL is routine for all cases.
Routine for all cases. Okay.
You attach the capsular remnant to the CAL in all cases.
In all cases. Okay.
Yeah. Basically, the CAL is attached in the middle of the coracoid on the lateral aspect. So the CAL capsular repair actually makes the graft partially intra-articular. That's what they say. So if you do a Bankart repair, the whole graft is extra-articular, right? If you combine the Letaje with the Bankart. Whereas if you repair the CAL with the capsule, then part of the graft is intra-articular and part is extra-articular. I do it routinely in all cases, irrespective of the thing.
So I'll shoot all the questions to you first, take all the inputs from you, and then shoot to others. Okay.
Yeah.
I used to take sometime in past, but sometimes my personal, what has happened, sometimes the CA ligament comes in right in front of my eye. So I am sometimes unable to see where exactly I'm placing my graft. It kind of gives me an obstruction. So off late, I have not been doing unless and until I am like, what I told you, like I know, okay, he has dislocated 100 times. So I may presume that there is a capsule, maybe poor quality, then I take. Otherwise, once in a while, it was hiding my, where is the glenoid? It right comes in front of you.
Totally agree. See, sometimes the CAL attachment can be so thick that you might actually feel that the graft is a little lateral. And many times, if you actually err on putting your graft a little lateral, you might have to erase the CAL completely and burr the lateral aspect of the coracoid. In that case, you have to sacrifice the CAL stump. But what I actually do is I press the CAL down and then push, so that, in that video also, if you see the CAL stump actually is folded inferiorly so that you actually feel the bone nicely. But I agree, that's a problem. Sometimes the CAL stump can be thick and mimic, a lateral overhang. Yes. So if you don't have the CAL stump and you got a good capsule, then actually you put an anchor and you can repair the capsule to the glenoid. You can use an anchor. So that's not a problem.
Technique. Okay. Second is, Karthik, can you please tell a tip? Because you see, often what happens, unless and until when these screws are placed, through the your coracoid into the glenoid, they have to be as parallel to the surface, because the more the angle increases, it goes towards the suprascapular notch. What is your tip? How do you do that? Because often you said that you make the incision smaller. The minute the incision is smaller, retracting the medial side is extremely difficult. Muscular people, your wrestler and all, there's so much of bulk.
Yes.
So you have to be as parallel and not more than 10 to 15 degree, because more you are, it goes oblique, may go into the notch. You don't even know. What's your tip?
As shown in the video, the first thing is I put a Homan and clear the labrum, remove the labrum off, then put a periosteum.
Karthik, see, I wanted to bring this topic. When we actually, whenever I have done this Latarjet, in fact, to clear the medial side, to place your graft, you have to remove the labrum. I am always surprised at how to do the labral repair.
You can't do that. You can't do a labral repair. You actually have to only repair the capsule. I don't think it's possible to preserve the labrum and do a Latarjet. I mean, if you have to preserve the labrum, you'll have to lateralize the labrum quite a bit. You can only leave the labrum, not any capsule attached to it or any periosteum attached to it. So that's a
most of these cases, Karthik, they're all ALPSA type lesion where the labrum actually where your graft is going to be. Now, to clean up that area, you need to remove the labrum. It has always bewildered how to do the labrum.
If somebody claims that they do a labral repair along with Latarjet, I don't think it's it's not.
I'm bewildered, but I would love to see those techniques. So okay, so you clear up that area and you also try to
remove the labrum, use a periosteum, and then have a nice anterior glenoid retractor. Place it all the way medial as much as you can, and that will give you a very nice view of the glenoid neck. Once that is there, it's very easy to know the direction of the screw. The only thing is you should not point it superiorly, because if you go superiorly only, it will go and hit the notch. If you direct it straight, rather not inferiorly but straight, then it goes straight into, and then that's the alpha angle or whatever it is called. It can be between 0 to 15 degrees, so it's not a big problem. Up to 15 degree, you can angle it medially. It doesn't matter.
And in your personal experience,
I think the problem, one thing, I think the problem comes when you're operating on normal glenoid.
Okay.
The normal glenoid got a full glenoid, and then on top of it, when you place a graft, that's when you have a problem. If there is a bone loss, it's already a flat bone surface on which you are placing it. So in that area, you will not have a problem with screw placement. Only when you are pushing the indication and doing it on a normal glenoid, that's when you have to be a little bit more careful.
Last question.
Vivek, I think we should move on because it's already half an hour late. So.
Just last question. In how many cases you ended up placing slightly superior, but your patient had absolutely no problem? Like in all my cases, except one, I have placed every time almost right in the inferior part. In one case, I did put up somewhere in between, it was not, patient didn't had a problem. So my question to everyone, do you really encounter a clinical issue or is it just a radiological problem?
Yeah, as I pointed out, one case I had a transient infraspinatus atrophy. At 3 months, the patient had complete atrophy of infraspinatus. I was shocked.
Karthik, not the screw, the graft. Slightly superior.
Oh, the graft, if it is slightly superior, I don't think it's a big problem. But ideally, it needs to be below the equator. But I don't think it's a huge problem if you place it slightly higher.
It did happen to me once, but patient didn't have any problem at all.
Wait, may I add? See, when I place the graft slightly superior, the screw also goes superior, and the chance of this nerve injury is a little higher.
That is agreeable. Completely agree.
But whether it happens with your particular case or not, I think it's a chance factor, because each patient's anatomy is variable. But when you're going higher, the risk is higher actually.
Completely agree. So thank you, gentlemen. Thank you, Karthik. Wonderful presentation.
Thanks very much for having me.
Amol has raised a query. I think how many of us do the congruent Latarjet? I mean, I don't do. Karthik doesn't do, because our Latarjet, this coracoid is a little thin, so everyone is scared. We have not
we will even split regular. I mean, doing a regular technique also, sometimes if we can split the coracoid, Indian coracoid. Yeah.
Yes. Okay, so we move on to Nitin. Please proceed.
Can we give Dr. Nitin access, please? Screen share and start, Dr. Nitin. Thank you.
My video should start playing.
Sir, he share himself, sir. I share his video, or he share?
Should I start sharing my screen, or is my video going to play?
What you want, sir?
You
I
start
have
sharing your screen and start off.
Okay.
I have also your video.
Yeah, please play
Oh,
it
you
then.
have the video, then play it, please.
Okay, sir. Just
I'm Dr. Nitin Kumar, and I'll be presenting a video of acromioclavicular joint fixation, both open and arthroscopic. Firstly, I would like to thank the organizing committee of OASISCON for giving me this opportunity. So it's a very common injury. Up to 10% of shoulder injuries are acromioclavicular joint dislocations. Surgery is indicated in grade 4 or 6 dislocations and in selected grade 3 dislocations as well. Multiple surgical techniques have been reported with various complications, and various results have been published, both arthroscopic and open, and I'm going to present to you both the techniques over here. This is a 38-year-old gentleman who is a kabaddi player and sustained a grade 5 acromioclavicular joint dislocation. And in this case, we chose to do an open reconstruction. So this is an open acromioclavicular joint reconstruction, left clavicle. So a standard incision is made starting from the coracoid process, a vertical incision, and then the deltopectoral fascia is opened to expose the distal clavicle. Once you expose the distal clavicle, about 5 millimeters of the distal clavicle is excised, as you can see here. Next, you isolate the coracoacromial ligament. This will help us in biologic fixation. So once you isolate the ligament, we're going to tie stay sutures using fiber wire. So that's your coracoacromial ligament isolated. Next, we're going to measure about 2 to 2.5 centimeters from the resected end of the clavicle, and then we'll be passing a guide wire. Guide wire. A nitinol wire and a guide wire is used to pass through the distal clavicle. Next, we're going to drill at the base of the coracoid. A cannulator drill bit is used, and again a nitinol wire is used to pass the free ends of the dog bone button. The dog bone is now passed from under the coracoid process. And once the dog bone is passed under the coracoid process, next we will be using another suture passer with nitinol. This is to further augment using a semitendinosus or gracilis graft. And in this occasion, we have used a semitendinosus, and a whip stitch is tied, and then the semitendinosus graft is passed from under the coracoid process, and it is brought posterior to the clavicle. And finally, now we are going to bring the sutures on top of the clavicle and leave them aside. Then the coracoacromial ligament is tied at the distal end of the clavicle by drilling two holes with K-wires. And then the coracoacromial ligament is tied to the distal end of the clavicle. Then the dog bone construct is completed as you reduce the clavicle down and tie the
dog bone on the superior end of the clavicle. That stabilizes the clavicle nicely, and a further final construct, which is the semitendinosus, is tied upon itself. And we tie that using figure of 8 fiber wire suture. And that will complete the technique of acromioclavicular joint reconstruction using biologic fixation of coracoacromial ligament, dog bone implant, and also augmenting using a semitendinosus graft. Following this, the deltopectoral fascia is closed. And that is pretty robust construct. That was the open technique. I would like to quickly show you another video presentation of an arthroscopic technique. This I had to borrow from my good friend, courtesy Dr. Chandrasekhar. This is his video, which I'll be presenting. So this is again a grade 5 acromioclavicular joint dislocation, as you can see, and this was fixed using arthroscopic fixation. So as you can see, the undersurface of the coracoid is nicely prepared until you reach the base of the coracoid. Your accessory portal will be antero-inferior and a little lateral. You'll have to take 2 accessory portals, one far lateral. There you can see the undersurface of the coracoid, and this is the Arthrex device which is being used. After drilling the undersurface of the coracoid, you are now passing the dog bone with the fiber wire technique. So that is the dog bone being presented under the coracoid. It seems to be tangled in the sutures. So it is untangled. Once it is untangled, there you can see that's nicely sitting on the undersurface of the coracoid, and superiorly it is tied on the upper surface of the clavicle, and once it is tied, the clavicle should nicely stabilize itself. That is the upper surface of the clavicle, and the post-operative X-ray, you can see a nicely reduced distal acromioclavicular joint. Post-operative rehabilitation protocol. I use an abduction sling to protect the repair for 4 to 6 weeks, and supine passive shoulder range of movements are started straight away from day 1, and the active shoulder range of movements are started after 6 weeks. And then rotator cuff strengthening and scapulothoracic exercises are started after 8 weeks. Return to sports after 3 months. Thank you very much.
Thank you, Nitin. Fantastic demonstration. Nitin, if I understood from your video, it is like a 3-in-1 technique. We were done ST reconstruction and along with dog button. Am I right?
Correct, yeah.
So is it for the chronic or is it for acute?
Majority of the time for chronic, especially in grade 5 to 6 acromioclavicular joint dislocation. And I would use this 3-point technique only for the absolutely high demand patients, like wrestlers or kabaddi players or contact sports people.
I think you solved some misery of mine also, because in mine, few of my cases, when I did just ST reconstruction with support with 1 or 2 tapes, it actually tends to fail. It does becomes loose. I don't know. It has been reported in literature, so there's nothing new about this. But I believe anyway you are there, you can also add the CA ligament to the stability, and then dog button. Why not just to use 2 tapes? What dog button gave you extra?
So dog button is good for your superior inferior stability.
No, that is fine, Nitin. Dog button, 2 dog button. If you need to do arthroscopic, fantastic. But when you're doing open, when you're putting ST modified Weaver done, why not to just loop around the 2 tapes and tie it very hard?
So that's what. So the semitendinosus or any of the graft that you're using mainly is going to give you the anterior-posterior stability as well, along with your inferior-superior stability. Your dog bone is mainly going to give you the inferior-superior stability. So I think the AP stability is very, very important. Given a choice between using dog bone and semitendinosus, I'll skip the dog bone and use a semitendinosus.
But for the AP stability, anteroposterior, they actually divert the part of the ST into the acromion.
Correct.
You do that?
No, I don't. I think so. I'm doing because I'm doing a 3 technique. I think that's enough stability for both directions.
Deepti, what is your okay? And this question actually to our Chandra. Chandra is around quickly. Chandra. Okay.
I'm here.
Yeah, Chandra.
Yeah.
What is your experience in doing the dog button with dual tape in the acute ACJ, especially type 5? Because once me and Ram were sharing, Ram was like of view that in type 5 you can do the dog button, but it is better to repair the deltoidotrapezial fascia, because we recently sent our article the journal got accepted. And what we found that in type 5, in type 3, fantastic. The dog button does a great job. But in some of the type 5, you get some amount of loosening. Patient may not have a symptom, but there is a bit of, widening of the coracoclavicular distance in the due course of time. So in type 5, do you also add an open repair, or you continue to do all arthroscopic? Acute. I'm not talking about chronic.
Yeah. Acute, I do an arthroscopic repair. I don't open. But again, at the same time, I do add an additional suture tape through the acromion into the lateral end of the clavicle for anteroposterior stability.
Okay. But then how do you do? You do it open, huh?
No, we can do it arthroscopic. You can go to subacral space.
You are doing it still arthroscopic. Okay.
Just make a hole in the with a small guide wire, thick guide wire, 3 mm guide wire in the center of the acromion, and you reroute it into that lateral part of the clavicle. And here I make an additional small hole anteroposteriorly. Not supra-inferiorly. Supra-inferiorly is for the dog button.
Got it.
Lateral part of the clavicle, make an anteroposterior small hole with K-wire, and pass the suture through this clavicle and then tie it. Okay.
Nitin, what is your take on hook plate in acute ACJs?
Completely. Well, I haven't used a hook plate at all, but firstly, it is a 2-stage procedure. You have to remove the hook plate.
I agree.
Secondly, every time you use a hook plate, the acromiclavicular joint is disrupted. And once you remove it also, there's always a little bit of chronic pain which remains in the acromiclavicular joint. So I'm not a big fan at all.
Okay, Pratap sir. Unmute. Yeah. Have you used the hook plate sometime in past?
Yes, in past only. Not now. Completely abandoned.
Completely abandoned. Okay.
Completely abandoned, yes.
Anyone in the panel who continues?
Vivek.
Yeah, Pratap sir, continue.
Vivek, for type 5, either acute or chronic, I'll use a mini open only. With a modified Weaver done, yes.
Okay, Ram sir, your view on one hook plate, and what about doing the mini open deltoidotrapezial fascia repair in the type 5? Unmute.
Oh, okay. In type 5, I think as you correctly pointed out, it is very important to get the anteroposterior stability. That is the acromioclavicular repair. So if I do arthroscopic, but the arthroscopic assisted, basically to put the button in the undersurface of the coracoid in the middle without violating your side ligaments, arthroscopic adds an advantage. But as I open the top, I do my small opening and take the tape across to acromion. Or if I use in a chronic situation a tendon graft, I also take the tendon graft across to acromion and fix it. So basically, you achieve coracoclavicular as well as acromioclavicular fixation. Otherwise, if you do only coracoclavicular fixation, there is the tendency to be having some sort of residual subluxation is high.
I know. Yeah, that's what
And
I
the hook plate, when you do a open hook plate, it address the it address. I don't no longer use it, but I have done in the past with good results. So we can't say completely no to hook plate, because in hook plate you achieve a direct acromioclavicular repair as well. I mean, the deltopectoral fascia sleeve is restored, whereas in the original technique of arthroscopic, this was neglected. So my point, my advice is that when you do a type 5 ACJ, do not hesitate to make a small opening on the top, make sure the joint is reduced, and repair the deltopectoral fascia at the least. Supplement the AC with a tape or a graft if necessary.
Absolutely. And I actually only published our study. We did compare with the hook plate, and surprisingly, there's hardly any difference.
Yes.
I said two-stage fascia, that's the only problem. But in the loss of reduction is much more higher in the.
But as Nitin pointed out, I think in a demanding patient, athletic, or whatever, you need to do a robust arrangement. I think you need a graft.
Yeah. When I agree what Nitin did, it's a fantastic job, especially in robust people. You need to, I think, combine all three. So I'm going to do this 3 in 1 now.
Yes, mechanical device and a biological device.
Mechanical plus biological both. You do alone biological, there's a chance of failure. So thank you, gentlemen.
Thank you. Thanks. It was a fantastic time.
And we had some really good takeaway points.
Thank you very much, Vivek. I think we are going very slow, and I think we might actually not go through one session. So we probably should respect our international faculty and probably go on to his talk first. Amol has taken the pain to get up in the morning and be with us, and I think we should have his talk first. So I'd like to introduce Mr. Amol Tambe. He is my colleague and a good friend from UK. He is a prolific shoulder surgeon. He works in University Hospitals of Derby, and he's recently been appointed as assistant professor. So Amol is going to show us some cutting edge technology in shoulder surgery, which I think will be the future for shoulder surgery. So Amol's talk, please. Thank you.
Good morning. Greetings from England, where we are now in our second lockdown period. I hope things are better where you are and that the situation is improving. It is my absolute pleasure to present in this OSSCon meeting, and many thanks to the organizing team for the invitation. I'm going to talk to you about navigation in shoulder arthroplasty. So GPS and satellite navigation has become a routine part of our daily lives and travels. Not only does it give us real-time information on traffic, road closures, parking, etc., but it also gives us a continuous update of the landscape ahead of us. And this is, of course, very important. Navigation is not new in orthopedics. It has been in use since the 1990s. Examples are insertion of pedicle screws in spinal surgery. Navigation has also been used in total knee arthroplasty, total hip arthroplasty, especially resurfacing arthroplasty. And I'm sure some of you would have had direct experience of using this in your own practices. But why are we today talking about navigation in shoulder surgery? Well, the key issue is the glenoid, that precious little piece of bone in the shoulder. Glenoid component failure dictates long-term clinical outcomes in shoulder arthroplasty. Malpositioning of the glenoid component during surgery is easily done. Also, glenoid implant fixation is complicated by a number of things. It could be that you have deformity of the glenoid, or there is major change in the version or inclination of the glenoid. Poor bone stock is something we see commonly in this area. Limited exposure and access to the scapula becomes a big issue. And of course, we then have lack of reliable landmarks around the shoulder, especially when you're operating on the small confined area around the glenoid. So, accurate placement of the glenoid component is the key parameter for joint survival. And basically, you get one good shot at the glenoid. you have to make the most of it. Most of us would try to do this, but the issue really is, can we do it better? The key issues with the glenoid that we have discussed so far mean that the shoulder joint lends itself very nicely to navigated shoulder surgery. Surgeons have their own inbuilt navigation system, and we all have our own way of how we do our procedures. And what we are essentially trying to do is we are trying to match the preoperative images to intraoperative findings. However, this navigation relies on the surgeon's knowledge of anatomical landmarks around the shoulder. The surgeon may use jigs or guides, and very often it boils down to eyeballing or palpating, and sometimes guesswork or intuition. And we have all been there. So it has been shown, however, that the traditional methods of glenoid implantation, even by highly trained surgeons who use modern techniques, are limited in accuracy. And this has been shown by Nguyen in 2009. Furthermore, even in expert hands, the glenoid component would have been malpositioned in approximately 38% of cases. And this was recently shown in JSCS by Shaw. So you can see that there is a degree of imprecision of implantation when it comes to the glenoid. So realistically, what we have is a map with all the imaging that we have. And with evolving technology, we now have the tools to navigate this map. So we should use it to our advantage. You will, of course, think about evidence, and you're going to ask me, is there evidence to back this up? Well, there is now increasing evidence as surgeons have started using navigation in shoulders in their practices. This clinical study of more than 30 cases published in 2019 showed that navigation improved base plate fixation in reverse arthroplasty by reducing the incidence of central cage perforation, increasing the average length and a screw purchase that you could obtain when fixing the base plate, and also by allowing significant changes in angulation of the screws in the axial and coronal planes. Another study by Green in 2017, in this lab-based study, surgeons aimed to create neutral version and inclination when preparing the glenoid for implantation. And you can see this in the scatter diagram. The blue dots indicate the non-navigated method, and the orange dots indicate the navigated method. You can see that the blue non-navigated dots are widely scattered, indicating that the implantation was imprecise, whereas the orange dots are closely clustered together around neutral version and neutral inclination, indicating that navigation helped the surgeons in a precise implantation of the prosthesis. This is another level 2 therapeutic study by Kirscher, where the mean correction in retroversion, which was achieved by the navigated group, was much more accurate and consistent when compared to the non-navigated group. And you can see in the blue box that the correction of navigation achieved was much more precise, as you can see in the blue box, compared to the non-navigated group, which you can see in the orange box. A similar study in 2015 by Wen compared the traditional and navigated techniques. While there was no difference in the accuracy of the screw or the central cage at their entry point, there was a significant difference when it came to where the end of the screw or the end of the cage ended up lying within the glenoid shelf. And hence, the navigated base plate and entry point precision was improved with navigation technique. This, of course, brings us to the advantages of a navigation technique. What all these previous slides are telling us is that navigation helps with accurate positioning of the central post or the central cage and the screws. It reduces the error for implant version and inclination. It improves consistency with which you will place the glenoid implant onto the glenoid face. It reduces the deviation from your preoperative plan. It also reduces complications. For example, if by using navigation you can be absolutely sure that the screw is well placed within the glenoid vault, then the chances of that screw causing injury to either the suprascapular or the axillary nerve are, of course, reduced. It has also been shown that navigation can be a useful teaching tool because it increases the awareness of trainees to surgical errors. Thus, more accurate placement, more reliable results, and a reduced range of positioning errors when it comes to implanting the glenoid. We now come to pre-op planning. So this involves a CT scan as per company protocol. The CT scan is then segmented with a special software, and this gives us three-dimensional geometry, including the version and inclination axis, which are calculated. This program is then fed into a planning software tool, which allows the surgeon to create a patient-specific plan to correct the glenoid deformity or to get the correct version or inclination as the case may be. Once this is done, the entire plan is loaded onto this unit. It's like a navigation console, which can be fitted on the side of the patient during surgery, and you'll see this in a second. So this is an intraoperative picture on the left. The GPS unit is set up on the side of the patient in clear line of the open joint. The coracoid is exposed as standard, and a tracker is placed on the coracoid. Using an optical tracking pen, the surgeon can then register various landmarks on the glenoid. If these are optimal or good, then they will appear as green. Any red areas or red dots indicate that the registration is incorrect, and this will have to be repeated. Finally, the picture at the bottom shows me using the central drill, and you can see again that there is an optical tracker mounted on it. This tracker is talking to the navigation screen mounted on the side, and it allows me gives me real-time information on how my reaming and preparation of the glenoid is progressing. Let's consider a couple of cases. The first case is a 76-year-old male with significant shoulder arthritis, which you can see. There is proximal migration of the humeral head, and clinically his cuff was deficient. There is also quite prominent retroversion that you can see on the axial image. Given the degree of deformation and retroversion, I decided to use the navigated technique here. These are steps in planning and a few screen captures from the planning software. It calculated the retroversion as 17 degrees with a pi concave glenoid, and you can see that here. It's a B2 glenoid, humeral head in fixed posterior subluxation. And there was an inferior inclination of 5 degrees, which is absolutely acceptable. This is again an image from the planning software where we have worked out that we are going to use 8 degrees posterior augmented glenoid to correct the retroversion from 17 degrees to 5 degrees. Also, by reaming the glenoid anteriorly by about 2 millimeters, it is going to give us a glenoid base plate that is fully in contact with the glenoid with a final retroversion of 5 degrees and inferior inclination of 4 degrees, which was very acceptable to me. You can see here another view, and you can see that there are posterior osteophytes, and you can see, of course, the reaming that is required to get the desired correction here. What you see on this slide is the planned position or the final position of the glenoid base plate, showing that the cage of the base plate is fully contained within the glenoid vault, and we now have the correction that we had aimed for, which is the 5 degrees retroversion, which is an excellent correction from the 17 degrees that we started with. This is a introp screen shot from the navigation unit. The yellow bullseye that you see on the glenoid here shows me the planned entry point for the guide pin, and my guide pin, which has an optical tracker mounted on it, will have to line up exactly with this bullseye on the glenoid. You can also see that on the right-hand side, the reaming is in progression, and this is the process of taking off the 2 millimeters of glenoid anteriorly. The real benefit here is the real-time feedback, which I get as I progress through the procedure. And this is truly amazing, as this gives you a sense of having a 3D vision when looking at a 2D screen. This is, again, preparation of the central cage. And you can see that I've been able to exactly replicate the planned inclination and version, and that the drill guide is totally contained within the glenoid vault, exactly as I had planned. And this again reassures me at all stages of glenoid preparation that I'm going as per plan, and I'm going to achieve the correction that I had planned for. What we have here are the post-op images from this case. This is, of course, a posterior augmented glenoid, and while you can't see the augment very well at the back, overall, I'm quite satisfied with how these x-rays look, with good screw lengths and good position of the cage and the implant. And this is now the patient a few months down the line. I've obtained a remission from the patient. He's got excellent flexion and lateral abduction, as you will see in a minute. He was fascinated that we had used this new technology for his shoulder surgery, but also quite pleased with the result. Rotations can sometimes be a problem with reverse arthroplasty, and some limitation in internal rotation, but overall very functional. And this is another case. This is a 69-year-old female who had a resurfacing shoulder arthroplasty a number of years ago, which was then revised to a total shoulder replacement some years down the line in another hospital. Unfortunately, this failed. She developed infection. She also developed loosening of the glenoid implant that you can see on the X-ray that there has been a movement of the glenoid implant. This is a TM back glenoid. They generally don't move, but in her case, I think the infection propagated that movement. Essentially, from these X-rays, you can see that we have 4 problems. We have infection, we have bone loss on the glenoid, there is failure of the cuff, and there is instability, clearly seen on the axial view, where the implant, humeral implant, is subluxing anteriorly. Clinically, this lady had a pseudoparalytic shoulder with pain. She had redness around the shoulder wound. And all in all, this was one case with a number of issues. So we planned a stage 1 revision, and as with all revision cases, she had the full workup, blood tests, aspiration, and during the first stage, we removed all the implants. And despite the loose-looking glenoid implant, it did come out eventually with a little bit of glenoid bone. And this is, I've seen this happen often when there is a TM packed glenoid implant. Removal of implants was followed by implantation of a cement spacer, and I've included 2 grams of vancomycin within the cement spacer to provide local antibiotic delivery. These are images of the CT scan with the cement spacer in situ. You can see clearly the extent of glenoid bone loss on the axial cuts. So she had antibiotics for about 6 or 7 weeks, and then after a full blood chemistry and further aspiration, we planned for the second stage. These are 3D images of the glenoid defect that we were going to have to deal with. And as per the Antuna classification, this mapped out to a severe combined defect. Given the extent of the glenoid deformation, it was only logical that I would want to use navigation. These are a couple of images from the planning stage. The top one shows a standard base plate, which has the standard cage length, and the bottom one is the extended cage, which is the 26 millimeters. The most ideal situation here is to make sure that that at least 10 millimeters of the extended cage anchors in the native bone, and you can see this here. And with this positioning, we still had quite a big gap left between the native glenoid and the back of the base plate, which would require a bone graft. And now the planning software also allows me to calculate the dimension of the graft required. Having done that, I'll show you a few pictures intraoperatively. So this is a femoral head allograft. I implanted the base plate on top of the femoral head allograft, and then I was able to trim this graft down to the correct size as measured from the planning stage. And a couple of key points here are the fact that you have to make sure that the graft encircles the cage in a circular fashion so that it can't escape when you're implanting the base plate. And secondly, you definitely need part of the cage jutting out from the bone graft, because this is the part that is going to engage into the native or the parent glenoid, and this is very important. Further screenshots from surgery. The top left-hand corner shows you the exposure of the glenoid, and really exposure of the glenoid is the key. You can see the number of retractors I've placed there. So I did get good exposure, and this allowed me to navigate this quite nicely. You can see that I've got mainly green areas on the deformed glenoid, meaning that my registration was complete. You can see that the entry point for the guide pin was quite low and posterior, not something I would have been able to recreate if I wasn't using navigation. It would have been tricky. I used a burr to freshen the bone, to take the bone graft, and overall, I was then, having prepared the glenoid, I was able to implant the glenoid with its bone graft onto this prepared area. These are post-operative X-rays. You can see these are a few months down the line. You can see the bone graft right there. It is incorporated quite nicely. Most importantly, you can see the excellent screw lengths that I've managed to get here because of use of navigation. And why is this important? Well, the screw lengths mean that I was able to get a good compression of the bone graft between the base plate and the parent glenoid. And I think this was only possible because under vision, I could see that all my screws were contained within the bony vault of the glenoid. And of course, this is a big advantage when using navigation. And these are some pictures, 8 or 9 months post-operatively. This lady is very happy with the outcome. She does have some limitation in rotational movement, but she was absolutely grateful with the movement she had accrued. And of course, her pain had gone. You're going to ask me, what are the problems with navigation arthroplasty? And of course, there are problems. I have listed a few. It is being shown in a few papers that surgical times can be about 20% longer. In my experience, as with any learning curve, this is a problem to start with, but as you get better at it, this improves. And my operating time with navigation is probably 8 or 9 minutes longer, and it's definitely worth those 9 minutes. You can have unintentional or unrecognized movement when you are trying to register on the glenoid, and this can render the data invalid. The tracking device on the coracoid may become loose, and if this becomes loose, it is a problem because again, your data becomes invalid, and sometimes you have to convert from navigated to a non-navigated procedure. And of course, this comes with a cost. New technology always comes with a cost, and this is something you need to be aware of when considering navigation. Lastly, future. What does the future hold? Orthopedics is technology driven, but the technology we use should, of course, be evidence-based, it should be cost-effective, and it should bring tangible benefits for the patient, but at the same time, make life easier for us as surgeons. Hopefully, my talk has given you a flavor of a navigated shoulder arthroplasty, and some of the examples I have shown you have given you an idea of what can or cannot be done with this navigation method. Many thanks for listening, and hope you stay well and stay safe. Thank you.
Thank you very much, Amol, for that excellent talk. I think it definitely has given us a flavor of what is going to come, and has given a good overview of the cases, and the case mixes you have shown are brilliant. First, I would like to take some questions from the panelists, if there are any. Please go ahead and ask Amol if you have any burning questions.
Amal?
Hi, good
Can you
morning.
hear me? Pratap.
Yes. Hi, I'm Pratap.
Yeah. Amal, that graft one, that is while you are navigating, that will measure the size of the graft?
Yes, so using the software, depending on how lateral you're going to place the base plate, there is a method by which you can work out how many millimeters lateral you're going. And by working 360 degrees, you can actually work out the dimension of the graft, or the thickness of the graft along 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock positions. So you can get the entire graft dimension worked out quite nicely. And you can then just replicate that once the graft is on the back of the base plate.
Okay, that's automated. Yeah. Okay, thank you.
Well, it's not automated. You can work out what the dimension of the graft is going to be, and then you have to manually trim the graft down to the desired dimension. Yeah.
Dr. Amal, this is Dr. Chandrasekhar.
Hi, Chandrasekhar.
Yeah. So, I mean, do you think navigation is necessary in each and every case, or do you think navigation has an advantage in complicated cases?
So I totally agree with your thought. I don't use navigation for each and every case. I use it for cases where I feel that doing a traditional technique will not allow me to get the best of what the glenoid has to offer. But of course, to do navigation cases, you can't directly go to a difficult case. So you have to do a few straightforward ones to get a handle on the technique.
Learning curve.
But most cases I will do non-navigated, but select cases I will do navigated.
And any idea about this patient-specific jigs?
I have used patient-specific jigs, but patient-specific jigs will allow you that one-shot entry, and they place your central guide pin. Beyond that, they don't allow you screw placements. For example, with navigation, each and every screw you can pass under vision. You can change the direction and make sure it goes exactly in the vault or in the best area of purchase in the vault, which a jig will not allow you to do. So I feel navigation is slightly more advantageous when compared to the jig.
Okay, thank you very much, Amul. For want of time, I think we need
And then can I just make one comment?
Okay, Amit, definitely.
Sorry. No, Amul, this, I think navigation, when it came from knees, I think it was just splitting hair, but here it has definitely come to stay. What I would certainly recommend is that you may not use navigation for all cases because there is a cost element involved. But the planning software, there is no reason why you shouldn't be using it in every case, because it costs you absolutely nothing. And all you need is a protocol for your CTs, which you can upload. And this is accurate within a millimeter of what the planning tells you, really.
Absolutely.
Okay, thank you very much. Next talk will be by Dr. Amit Modi, who is a teacher of mine, a mentor for me for shoulder surgery. And he has the, I think, the largest number of graft jackets done probably in the world. And he will show you exactly what he does and the results, and seeing is believing. That's what I feel. So just go through his talk, then you can believe whether the graft jacket works or not works. Thank you.
Thank you, Nandan, for the invite. I'm going to share my last 14 years experience of the use of a graft jacket for reconstructing massive irreparable rotator cuff tears. Now, massive irreparable tears are not uncommon in clinical practice in not so elderly group, and this is a real clinical challenge. We know from the natural history of full thickness tears that they will progress with time, they will retract, they will develop fatty changes, and a percentage of them will go on to develop cup tear arthropathies. So what are the options we have? Physiotherapy with using the Ainsworth regime is probably a good option for the elderly age group. Subacromial debridement can give you short-term relief for a couple of years, but by 4 years, only 17% have any beneficial effects. And similar is the case for partial repairs, where the results tend to deteriorate very rapidly over a period of time. Tendon transfers are not without donor site comorbidities, and what you can really achieve with them is very limited. The gains are very modest. Though recently, Bassam Al-Hassam has shown some very good results with lower trapezius transfer for posterior superior insufficiencies. SCR has been popularized by Mihata, where he uses 6 layers of tensor fascia lata and has recently reported his 4 to 5 years results. With balloon arthroplasty at present, the jury is neither in or out, and indications are very, very limited. You need an intact subscap. Reverse shoulder arthroplasty is not something I would want to consider in the younger age group, and that brings us in the domain of patches or augments. To keep this short, synthetic and xenografts just don't work. Okay, so that leaves us with human allografts, of which graft jacket is one of them. Not all human allografts are the same. They are all processed in a different fashion, and the success depends on whether the vascular channels are remain patent or not. And graft jacket is derived from human cadaveric graft, which has been specially processed to remove all the cells. So it leaves you with a scaffold of collagen with intact vascular channels through which your the host tissue can integrate into really. Now, no matter what graft you use, the properties don't match that of a normal tendon in any way. Okay, and for any graft to be load sharing, it has to stretch out before it can actually have a load sharing function. And of the grafts available, this study by Alan Barber shows that the pull-out strength for graft jacket seems to be the best. Now, one major difference between a superior capsular reconstruction and an interposition graft is that in an SCR, you're just anchoring the graft between 2 bony points, and there is no chance of it integrating with the rest of the tendons. Whereas with an interposition graft, the graft is sutured to the edges of the tendon, and the graft will integrate since the vascular channels are patent. So let me take you through the procedure which I've been doing. It's a very standardized procedure: beach chair position, standard Navas-McKenzie approach, superolateral incision. You undermine the skin and come to the deltoid, which is quite important that you elevate it with some osteoperiosteal flaps. And once you have elevated this, you do your standard acromioplasty, and you can see that that's a completely bald head where the tendon edges are still not even visible. The bursa is often hypertrophied, and this needs to be resected, and don't mistake it for the tendon. So once you have identified the tendon edges by rotation of the arm, you start replacing your sutures anteriorly and posteriorly, working all the way to the apex. Sometimes there is no apex, and there is closure is not possible to minimize the defect. More often than not, the defects are about 3-4 centimeters. Then you prepare the footprint by decorticating it till you get some fine punctate bleeding. This time you should have already decided you're using a graft and would soak it for about 10 minutes to rehydrate it and make it more supple. Once this has been done, you measure the defect size, fashion the graft, and the first and foremost thing you do is place your apical suture to the apical to the apex of the graft. And once this is placed, all your pre-placed sutures with number 2 ethibond, which are already in place, you start suturing it about 1 centimeter apart to the edges of the graft. It doesn't matter, you can do either the front or the back first. And this should be under just about adequate tension. Then you place your anchor to anchor the graft to the footprint. Now, previously we were using peak anchors and moved on to all suture anchors. Over the last 5-7 years, I've not been using any anchors. I just use transosseous sutures. And Once the anchor is in place, you resect the excess graft. Now, the graft comes in a size of 7 by 4 centimeters, and most of the defects are 3-4 centimeters. So last 5-7 years, instead of resecting the graft, I've been doubling it and using it as a double graft. The newer graft, which is available since last year, does not need to be rehydrated. So at the end of the procedure, I take the bursa and cover the edges of the graft. So you can see here you've got a complete coverage, good reconstruction of the bald head which was there. It's quite important to get a good transosseous repair of the deltoid which you have elevated, because the worst thing you can have in any shoulder surgery is a deltoid dehiscence, and you finish your closure. My post-op regime is quite standard: 6 weeks in a sling, followed by physio, which commences with active and passive assisted at 6 weeks, and progressing to therabands with resistive exercises at 10 weeks. So this is an example. He was my anesthetist, about 50 years old age. He had a small cuff tear to start with. I offered him an arthroscopic repair, which he refused. 2 years later, he fell from bicycle, and by that time, he had a massive cuff tear. Went on to reconstruct this with a graft jacket. You can see the completely bald head. He had the supra-infraspinatus completely involved. And that's his clinical outcome. You can see that he's made substantial gains from 40 to 50 degrees elevation to near full elevation. Pain scores have dropped from 8 to 1, and significant improvement in his Oxford scores from 20 to 40 plus. And it's quite important to note over here the smoothness of the rhythm which you can achieve following a graft jacket reconstruction. So this is his pre and post-op MRI scans, and you can see at 1 year, you've got a nicely integrated graft where this defect was, and you can similarly see this on the sagittal sections as well. I get a large number of failed cuff repairs and attempted cuff repairs, which were found to be repaired from up and down the country, and have been using the graft jacket with good success. Here you can see this gentleman who's had a failed cuff repair with the pre-op range from about 80 improves to about 160 following a reconstruction, with the pain scores down to 0 and Oxford scores gaining by about 24 points. And again, you can see over here the smoothness of the rhythm which he develops following the reconstruction. Now, this is an interesting one. He was a younger commodities broker in his mid-40s who had been involved in a rugby injury. So he had multiple surgeries elsewhere. He had an arthroscopic Bankart and a cuff repair as an index procedure. 6 months later, the same surgeon did a release with a revision cuff repair, and a year later had a further revision. And every time he went, he has medialized the footprint, and by the time he came to me, his anchor was lying at the dome of his apex with a massive irreparable tear. Again, he had supra-infraspinatus and the upper teres minor involved. And you can see following this reconstruction, the nice integration of the graft, both in sagittal and coronal sections. His Oxford score was close to 48, and the pain scores were down to 0. And you can see his function as well. He's got an excellent rhythm. It's actually difficult to tell which was the side which was operated over here. Now I could show you about 200 plus cases, pre and post-op videos of these graft jackets. I've done over 250 to date, and I can actually highlight probably about a dozen who haven't done quite well. So this was the same gentleman. This is the elderly patients. So normally these are the patients who would normally have a reverse shoulder arthroplasty after failed rehabilitation. And after having good success with the graft jacket in the younger, I have extended my indications. And this is a 74-year-old with a massive tear over 5 centimeters, defect bridge 4.5 centimeters. And again, an excellent outcome with pain scores down to 0. Gain in movements by 90 degrees in elevation abduction, and again, a significant gain in Oxford scores again. So again, you can see excellent rhythm, excellent range of movement at 1 year. And this is his pre and post op scan images. Here I can see nice integration again, both in the sagittal and the coronal sections. I've had an opportunity to scope a couple of them. This was at about 11 months. He kept having clicking sensations. And you can see over here, all you see over here at the top is the graft, which is nicely integrated. And that is the edge with the normal tendon. This person actually had a small tear in his graft, which was repaired with a single anchor. And I took some histology specimens at that stage, and this purple dots which you see over here are in the graft. And my histologist reassured me that these are host fibroblasts which have grown into the graft tissue. I have been doubling the graft over the last few years rather than wasting it if the tear size is between 3 and 4 centimeters. So what about the outcomes? So the first paper we published was in 2013, looking at a first cohort of 61 patients with a mean follow-up of about 3.6 years. The mean age at the time of surgery was about 62 years. These were all irreparable tears. Graft was used as an interposition, and mean tear size over 5 centimeters and 3 tendon involvement in 42. And it was quite striking that the pain scores were down to less than 1 from 7. A significant improvement in Oxford score gained by about 18 to 20 points, and about a 90-degree gain in elevation abduction. There were no graft rejections and 1 early infection which required washout. So we compared our outcome of graft jackets with partial repairs, and the graft jackets again outperformed the partial repairs, which we don't do anymore. This is a more recent publication, should be out in print next month, where I looked at my personal series till 2017. I'd done 192 cases, and 21 of them were over 68. These are patients who would normally have had a reconstruction with a reverse shoulder arthroplasty. And again, the outcome with the graft jacket was excellent. We managed to preserve the joint. Mean Oxford score gain of nearly 25 points, an excellent elevation. Now, this is a sneak preview. You are probably the first group to have these results. We have looked at our long-term outcomes with a mean follow-up of 9 years. The same cohort which we followed in 2013, out of the 61, 45 were available for review, and the mean age at follow-up was 70 years. Here you can see the bar in teal color, and the green one is at 1 year, and the teal one is at the recent follow-up. There's been no loss in the Oxford score and no loss in the range of movement. So generally speaking, if you have a good outcome at 1 year, the result seems to be sustained over a period of time. We had a very high satisfaction score of 8.4 out of 10, and the Hamada grading didn't seem to affect the outcome. So to summarize, I think a graft jacket reconstruction is probably one of the better options available for reconstructing massively repairable tears with significant, statistically significant improvement in range of movement, pain scores, and Oxford scores. We have now had the long-term results, which again show that the results are sustained over a period of time. And it's possible to use them in a select group of the elderly as well, instead of doing a reverse shoulder arthroplasty, where they have massive repairable tears with no significant degenerative changes. And our next project is to use them as augments in large tears, where we know which they have a very large retear rate, and see if they can reduce the retear rates. Thank you very much.
Yeah, please go ahead, Pratap.
Pratap, hi. How often you get that retear? Fortunately, that was a small tear.
Okay, now we have since 2013 done MRIs of all our patients pre and post at 1 year. So partial tears are not uncommon, but they don't seem to affect the clinical outcome. The most common site of the partial tear is posteromedially, because that is the place where the tendon edge has subluxed and it's more difficult to access. So now I use a scorpion suture passer to get that bite. But yeah, partial tears are not uncommon. And I said the most common site is that posteromedial site rather than at the insertion.
That's due to the access problem, isn't it?
Yes.
Okay.
So I think if you start using your scorpion suture passer, it becomes fairly easy, really. And the standard operating time from skin to skin is now about an hour and 5 minutes, or hour to 10 minutes, nothing more than that.
Odi, I have one question. Hi, this is Dr. Nitin here. So when you are deciding whether to go with the graft jacket, is there any specific cases which you would rule out, contraindications, in terms of a completely atrophic muscle? Would you still go ahead?
Yes, the fatty change doesn't seem to affect my decision making. The only ones which I don't use is patients who are immunocompromised and patients who have had previous infections. And obviously, if you have got degenerative changes, I wouldn't use that.
Dr. Amit, this is Dr. Chandrasekhar. I think it's great to see the results, but what do you think the mechanism that is working in this? Because usually we think that when the muscle is atrophied, there's a significant fatty atrophy, the muscle is not going to function anymore. Like when you compare a superior capsular reconstruction, there you are not been depending on the muscle, you are just creating a static restraint superiorly. It's a slightly different mechanism, what we call as a biological reverse shoulder kind of, mechanics are involved there. And what do you think that's working here with your graft jacket?
Okay, and now I have a few thoughts on it. I can't tell you definitely which one works. The first thought would be that it centralizes the humeral head under the acromion, and the deltoid takes over the function. But I can categorically say that this is not necessarily true, because the failures which I have had in 4 or 5 rugby players, bodybuilders who have got massive deltoids, and you would have expected them to do the best, but they don't. I think that what happens is when you have a long-standing tear, the whole cuff is scarred and retracted, and probably the suprascapular nerve gets trapped in there. So when you are actually putting this graft, you tend to probably mobilize the cuff, try to draw it a little bit towards the tuberosity, and that probably takes the tension off the suprascapular nerve, which can probably help with the pain aspect. And once it integrates, then I'm sure it actually plays a role in load sharing as well. So I think all three of them have some sort of effect in the outcome.
Any more questions? No, I think thank you very much, Amit, for that excellent presentation and impressive results. I think I have converted a few of them. People were skeptical about this, and as we were when we started off, but I think the results speak for themselves. Thank you very much. We'll go on now to the debate session, because we are running short of time. So I think we will do a part of the debate and then come back to our case discussions.
Is it available in India, graft jacket?
No, graft jacket is not, but I think Arthrex now has brought in a dermal patch, acellular dermal patch. Yeah, basically this is an acellular dermal patch. So
I don't think it's available in India at this moment, dermal patch.
Yeah. Just one good thing, Nandan, about the Arthrex thing. I said the success of the graft depends on how it is processed. So the graft jacket is, the Arthrex one is actually sterilized. The minute you sterilize it, the vascular channels scar up and collapse.
Okay.
So it's not necessarily going to integrate really.
Okay. Okay.
Okay, so we'll now play Dr. Pratap's scapular fracture conservative management, please.
Hi, everyone. I'm going to talk on scapular fractures, and I'm going to concentrate on non-operative management of these scapular fractures. Before going into that, let us talk about pathophysiology of the scapular fractures. To break a scapula, especially the lateral border and your spine of scapula, you need enormous force. And as a result, you can get a wide variety of the fracture pattern. So you need to individualize the fracture. When you get a fracture, invariably there will be soft tissue injury as well. Now, when you talk about a fracture, you need to talk about whether it's the body involved or the bony processes involved, or there's a combination. Now, a bit more about the scapula. Scapula is always an irregular bone, a lot of projections and a flat surface. There's a reason for that. It's actually considered as a multiple bones which is coalesced. And the projections that will give attachment to the muscles and ligaments to give stability and the muscle attachment. And it will also give a bony protection to the lungs and the back of the chest. Has got a larger surface area which is covered, well enveloped in a soft tissue and muscle with a lot of vascularity. So when you get a fracture, fracture healing is not an issue at the body. These are the facts about the fracture patterns of the scapula. Is less than 1% of all fractures. And when you get a fracture of the scapula, there's a high chance that your body will be fractured, followed by the glenoid process or glenoid. It's also associated with other sort of injuries, especially the ribs or the underlying lungs. You can get a pneumothorax, hemopneumothorax, or large hematomas, and even soft tissue avulsions. I talked about the bony processes, especially the bony processes like your coracoid process and acromion and spine of scapula. This will give a stable platform for attachment of the ligaments and the tendons. And also the medial border and lateral border will give attachment to the muscles, which will give which are the core stabilizers. But of course, surgery is indicated in a limited indications, especially with a floating shoulder or an open fracture, or complete loss of integrity of your glenoid. The other extended indications for the fracture fixation, which I am not going to discuss in detail. I'm going to have a literature review why I am supporting non-operative management of the scapular fractures. The first one, if you look at Christopher Libby's review article, all fractures, irrespective of displacement, were treated non-operatively, and excellent result with 86% of patients. It's only less than 1% patient had to have a fracture fixation. A second paper, which Dr. Scoffer's paper, 50 patients with a fairly good follow-up of 5 years. They were looking at the range of movement and the functional outcome. Range of movement were restricted, especially with the forward flexion and external rotation. However, there's no functional disability. That was the most important thing. And also, isokinetic muscle strength was normal and comparable with the opposite side. This is a very good review article. It covers most of what you need to know about scapular fractures from Mr. Pandey Illuster. It's a systematic review article which has got 32 studies included and a fairly large cohort. Now, most of the body fractures were treated non-operatively and had excellent results or satisfactory results in non-operative cases. And glenoid with the glenoid neck fracture with less than 1 centimeter treated with the non-operative management, excellent result. Another paper by Dimitrioulis had 49 patients displaced. They have included all displaced fractures, body fractures. They treated the patients on day 1 with the early passive and active range of movement. They also considered injury severity score initially, and then a different scoring system was used to assess it. They used a sling and the passive range of movement was used initially. Fracture healing in 6 weeks, and there's no functional deficit. There's minimal malunion, but no functional deficit. That's the most important thing. And the paper by Rebecca, number of patients is 12 patients. However, they have included severely displaced fractures, including more than 2 centimeter displacement and more than 45-degree angulation. Normally, the literature suggests, okay, you need to go and fix it. However, they included non-operatively, assessed with the DASH score and the ACS. Range of movement is expressed in percentage and had range of movement of 90% compared to the opposite side. More than that, patient satisfaction rate was excellent and had a long follow-up. If you look at Dr. Gossin's paper, so displaced fractures, displaced body fractures, 22 patients. They also looked at the impact of accompanying injuries and looked at the functional outcome with the DASH score, special shoulder test, and SF36. The range of movement was related to the other injury, associated injury. DASH and SST and range of movement were comparable with the general population for isolated body fractures without any associated injuries. But they also looked at the SF36 score, which is more global. And that one gave a very satisfying result for these patients. Now, the people of my generation will easily recognize him. Glasson Small, as an England pace bowler, was serving England team for nearly 7 years, and very successful. He had a springal shoulder with a limited scapulothoracic movement, but didn't deter him from going to the top level of the cricket team. So range of movement alone will not count. This is my own patient. There's a bilateral scapular fracture. Left side, you can see a scar, 9 months post-operative. Left side, I fixed the acromion with the locking plate, and right side body fracture with the hemopneumothorax that is treated non-operatively. 9 months, there's no difference. I don't think you can make out which one is which. When you look at the literature, there's a limitation. When you read the literature, it's always a retrospective studies. People use different classifications and different outcome scoring system. That's a limitation. And all the studies are based on X-rays, not on CT scan. If you look at the radiological outcome, there is no correlation between the clinical outcome and radiological outcome. So in conclusion, there's no level 1 or level 2 evidence in the literature as expected. And associated injuries definitely define the long-term result of the patient. And there are enough evidence in the literature to support non-operative management of scapular body fractures. As I said, radiological and functional outcome may not correlate. You get an angulated fracture, still patient will have a good outcome. A definite limited indications for surgery. It's limited, I'll repeat, there's only limited indication for surgery. Those are my references. And thank you very much for inviting me for Vyas's talk. Thank you.
Thank you very much, Pratap, for that excellent literature review on non-operative management. I think we will complete this with operative management, then go to our case discussions because we're running short of time. So we'll play the my talk on scapular fixation. And then speaking on the debate on scapular fracture operative fixation, Dr. Pratap has elegantly shown why we need to do
non-operative treatment for many of these scapular fractures, and it also described the anatomy, so I'm not going to touch upon those fields. Scapular fractures, if you look at the history, has been first drawn in 1700s, and then first radiograph was in 1900s, and the first detailed description of the approach was only in 1930s. And Jude had advocated operative treatment in 1960s. That is about nearly 200 years after it was first described. So there's been always a reluctance in fixing these fractures. If you look at the incidence, it is 3 to 5% of all shoulder girdle fractures and 1% of all broken bones. Most scapular fractures typically occur after high energy trauma. So 90% of them will have associated injuries, and they're very serious injuries in the chest. Associated injuries are mostly to the chest wall, lung. So we need to wait for these injuries to settle before we fix the scapular fractures. Neurological injuries are also common, so we need to assess the patient well. And the more local associated injury is the floating shoulder. And what is the floating shoulder? When the suspensory ligament, which is linking the whole of the arm to the body, is disrupted. So restoring this ring is very important when you actually fix the scapular fractures. The consequences of floating shoulders are that there could be non-union, malunion. More importantly, there is abnormal alignment of the shoulder girdle. So you can have problems with weakness in the muscles, subacromial impingement, and other problems with drooped shoulder. If you look at the pathomechanics, often there is forward displacement of the whole of the shoulder girdle. So hence there is change in biomechanics. This is some clinical assessment we have to do in all floating shoulder patients. If you look at the trends, only 12% of them were plated. This is a paper from Finland. Although the incidence is increasing, the rate of fixation had initially increased, then plateaued, and then again increased, but again is coming to a plateau. That means we are understanding these injuries better. Scapular fracture treatment, operative indications are for displaced fractures have always been controversial and inconsistent, because we have found this anatomy to be complex, and we are afraid of the approaches to the scapula. This is the same problem we had with the pelvic fractures. Dilemmas are, when do we fix the fractures in the scapula, and in the floating shoulder, what do we fix and when do we fix them? So if you look at the parameters which will help us decide this, the main one is the glenopolar angle, which is basically the line drawn at the articular surface of the glenoid with in relation to the body of the scapula, and degree of medial displacement of the scapula, which is the degree of medial migration of the glenoid in relation to the lateral border of the scapula, and also anterior and posterior displacement of the glenoid in relation to the body of the scapula, because the body of the scapula should glide on the thorax. The outcomes, if you look at the outcomes from 2002, there is this 31 patients in each group compared between operative and non-operative treatments, and they found there was no difference in return to work, pain, or complications. And the mean displacement, shortening were noted to be greater in the operative groups. That means there has been a bias in how the patients went into the operative group when compared to the non-operative group. And in spite of this, they went on to conclude that if there is less than 20 millimeters of displacement, then we don't need to fix this. So even though there is a bias, I think there is some meaning in this conclusion, because most of the time we don't fix fractures with less than 20 millimeters of displacement. Indications for scapular fracture fixations: all articular surface fractures like glenoid fractures, if there is a step of more than 4 millimeters, they should be fixed. And if it is an extra glenoid fracture, a glenopolar angle less than 20 degrees compared to the other side needs fixation. And mobilized, medialized glenoid of more than 2 centimeters as per the paper previously quoted, and anteroposterior displacement of greater than 2 centimeters, otherwise it will cause rubbing on the chest wall. Glenopolar angle, as I mentioned before, is the line drawn from superior to the inferior part of the glenoid, the articular surface, and angled with the body of the scapula. The normal angle is 30 to 45 degrees. That means the whole of the glenoid is actually facing either parallel to the ground or is facing slightly upwards. But if the glenoid is starting to look downwards, we need to fix it, because that will alter the way the shoulder joint moves. Is it clinically important? Yes. In 2005, this paper had shown there was a good correlation. And can we predict outcome looking at the glenohumeral angle? This paper in 2008 showed that there was a positive correlation between the GPA restoration and the shoulder function. So constant score of the shoulder with a GPA above 30 degrees was better than in patients with a GPA below 30 degrees. In 2018, that is 10 years afterwards, again, they came out with a similar sort of observations. And we noted that having improvement in GPA improved the constant score or the shoulder function. This is a case example of a posterior displaced body of the scapula. And there is also a rotational deformity of the glenoid. We fix the lateral border of the scapula. We do this in a lateral position with good access to the scapula and also a C-arm to monitor. The plane is between the teres minor and the infraspinatus. So it's a limited approach. So we don't cause much damage. That's the fracture reduction and stabilization with K-wire. And that's the finished after incision. And this is the X-rays after fixation. You see the glenohumeral angle has been restored like so. And that patient is the same patient here, has regained full function, is back to work. If you look at the floating shoulder, the options are either conservative, fixing the clavicle only or the acromion only, or fixing the clavicle and the scapula. So these are the three parameters they had looked at in this particular study, where they fixed both the scapula and clavicle in one group, fixed only the clavicle in one group, and the conservative treatment in one group. And they noticed that GPA after consolidation was significantly better in group A. That means the lateral border of the scapula has been restored in line with the glenoid. And functionally also, these patients did better. Clavicle fixation can correct the GPA sometimes if there is severely displaced fracture of the scapula. So you can correct the GPA by fixing the clavicle and restoring the length of the clavicle. If it is restored, we don't need to do anything to the scapula. We can leave it treated non-operatively. But if there is a displacement, which is not correcting with fixing the clavicle, then we should go ahead and fix the scapular as well to restore the glenopolar angle. That is the function after fixation. If the spine of the scapula is also badly displaced, we can use small plates, especially the plates we get off the volar locking system to fix the spine of the scapula, or even good, well done tension band wiring is good enough to fix the spine of the scapula or the acromion fractures, like so. This was a gentleman who had an acromion fracture as well as a glenoid neck fracture, which was fixed with a recon plate from the pelvic set, and he restored good function. This was a lady who had an acromion fracture with the lateral border of the scapula, again fixed with restoration of the lateral body of the scapula and fixation of the acromion. That was the function after about 6 months. So if you restore anatomy, you regain good function. To conclude, scapular fractures, assess the glenopolar angle and the degree of displacement, fix all fractures with glenopolar angle less than 20 degrees and also displacement of more than 2 centimeters. But if there is an associated clavicle fracture, you could fix the clavicle first, then reassess the GPA. If the GPA is not restored, then go ahead and fix the scapular fractures and the acromion fracture. Thank you. Thank you. Now we'll go ahead with the case discussions because we're running short of time at the moment. So I think at least we'll catch up with part of the case discussion. So please play the case discussion part which was pre-recorded. Thank you.
So I invite all the faculty who were participating in different parts of the South Indian states in this prestigious VIAS-ISKCON conference 2020. Unfortunately, we could not have a live conference, but yeah, we are doing this online program like any other conference this time. But hopefully the content of the program will not be any less compared to a direct program. So we have 5 stalwarts in our panel now today. Dr. Subramaniam from Vale Medical Center, Madurai, who is a very senior shoulder surgeon, and Dr. Ramchandran, a well-renowned shoulder surgeon from Chennai and current president of Shoulder and Elbow Society of India from MGM Hospital, Chennai, and Dr. Chirag Tonse from Fortis Hospital, Bangalore, and Dr. Karthik Selvaraj from Midwin Hospital, Coimbatore, and we have Dr. Vivek Pandey from Manipal Hospital, Manipal. Now, we have this today's session divided into 5 topics. The first topic is on frozen shoulder by Dr. Subramanian, and the second topic is about osteoarthritis of the shoulder by Dr. Ram Chidambaram, and the third topic will be a stiffness with cuff tear by Dr. Chirag Tonse, and the fourth topic will be by Dr. Karthik Selvaraj on impingement of shoulder, and the fifth topic is about instability of the shoulder of various treatment modalities by Dr. Vivek Pandey. So during this panel discussion, we want the panelists to present 1 or 2 cases pertaining to each particular pathology. And then we want the opinion of all the panelists on that particular pathology, both in terms of diagnosis and also in terms of management. So I want the panelists to present a case and then to stop before you diagnose it and to discuss any differential diagnosis or other modalities of investigations and how you arrived at that particular diagnosis. And I want to take opinion of the panelists on that particular thing. And then we'll take an opinion on the management. And finally, I'll ask the panelists to conclude what he has done with that particular patient. So I invite Dr. Subramanian to present a case pertaining to frozen shoulder so that we can start the discussion. Thank you. Dr. Subramanian, sir, to you.
Are you able to see the screen?
Yeah, we can see. Yeah.
Thank you, Dr. Chandrasekhar. First of all, let me thank you, the whole YSISCON committee, for inviting me for this webinar. And it's a little unusual for all of us that doing a panel discussion through the webcam. The topic for me today is to tell something about 1 case or 2 cases which may be pertinent to stiff shoulder. This is a very common scenario that we are going to talk about. So this being a general audience for YSISCON, I thought we should pick up a really basic one. So I want to put on something. A patient coming like a 48-year-old presenting with left shoulder pain for 4 weeks with no history of trauma. I wish to know from the panelists what will be the line of questions in the terms of history taking, and also what will be their examination, what they will be doing. You know, if a patient comes, this is a very common scenario that we all get through. Almost about 60 to 70% of shoulder practice for shoulder surgeons is only this scenario only. So let's make sure we are in the right direction in this particular scenario. So Dr. Chandrasekhar, I wish all the panelists to tell me what will be their line of history taking and what will be their clinical examination, what they will be doing for if they come across such a situation.
Okay. So I request Dr. Ram to give his opinion. Dr. Ram.
Yeah, okay. Yes.
With this history, what questions you are going to ask and what investigations you are going to ask?
I think the important key question in the history is the history of diabetes, because a painful stiff shoulder is without history of trauma more common in diabetes, and the pertinent clinical examinations to look for the range of external rotation.
Dr. Karthik? Karthik?
Yes. This is a middle-aged lady with a painful shoulder with no history of trauma. So Dr. Subramanian suggested, we have to have an open mind. As Dr. Ram suggested, I think the most common thing which flashes in our mind is frozen shoulder. But then we do see some osteoarthritis of the shoulder as well. They do present like this. So we need to always keep that in the back of the mind. From the history, I would like to ask about her disability. How much disabled is she? Usually they don't come out with the amount of disability unless we ask for the activities of daily living which are affected. Are they able to tie their hair? Are they able to undo their sari and shirt and all these sort of stuff? When we ask them, then they realize that they are actually very disabled. So that actually, and the history of night pain, I would like to know because night pain actually gives me a lot of input about what I have to do in terms of treatment. And the examination wise, I would like to go through the rapid sequence examination, which I do all the patients, where we check for everything right from range to strength. But I think the most important thing, as pointed out by Ram, was the passive external rotation in supine position compared to the other side.
So one important point is night pain. Night pain, I think we have to ask them, because that really tells us the disability. Because the most disabling thing, especially in a frozen shoulder, is the night pain. Okay. And then what investigation would like to have, Karthik? Investigation?
Definitely an X-ray, and the patient is not a known diabetic and hasn't been checked for sugar. I would at least get a sugar level. There are people who check blood sugar, thyroid, and everything at the same time, but at least a basic.
Yeah. Other thing to keep in mind is that this age group will also can come up with calcific tendinitis with acute pain, 4 weeks duration, severe episodes. So in an X-ray, you should look for that too.
Right. Right. Dr. Chirag? Dr. Chirag?
Subra.
Yeah.
Subra, can you hear me?
Yeah.
Okay.
Welcome you to Oasis Khan.
Subra, there are two things I want to rule out here. Oh, thank you. Subra, there are two things I want to rule out. One is impeachment, and second thing is a frozen shoulder. So I just want to know what is the profession of the patient, anything involving the overhead activities. Is it increased by overhead activities? Can he sleep on that side? And of course, the night pain. And can he have passive range of movement? Those are the things I just want to elicit from that patient. And of course, followed by the examination of the patient, where I want to see has got a passive range of movement. Has he got a pain in a particular segment of the range of movement? Those are the things.
And Chirag, what do you want to add anything, Chirag?
No, details have been shared on the screen. Hawkins test positive, night pain. So I think we are leading towards some diagnosis.
No, we want to know your opinion. Your opinion with the history.
What so far?
What you are going to specifically look in the patient's examination.
Yeah, so it depends on what population are we catering to. Is it an urban population or a sedentary population? Activity of the patient on a day-to-day basis, any sporting activity, any overhead activities, repetitive activities of the shoulder is something I wouldn't miss in my history taking.
Okay.
Let me summarize, Dr. Chandrasekhar. What I am saying is, I think so far, Ram Chidambaram told about diabetes, which is very, very important. Yep. And the night pain, Karthik was emphasizing, that is also very important. And Pratap was telling about overhead activities and basic activities of living. And Chirag is highlighting about more things also. Especially what is important is range of movement, where it's very important. What is it is passive movement is not present. Active movement, maybe passive movement is not present at all. Okay. So I'll just show this video of this patient's range of movement. Please identify what do you think is a problem apart from he has almost got full abduction and full forward flexion is there. And when he come to rotation, actively symmetrical, almost active. We're trying to do passively. Left side, he cannot do little more than what he thinks on the right side. That's the only point he has got. And his pain has been there for only about 4 weeks' time. I just want to run the video again. I want you all to see the scapula, how his shoulder blade is looking like. What I'm trying to highlight is a very subtle finding is that scapular dyskinesia is there in many patients who come with this initial problem. And the reduced external rotation is the very first sign of adhesive capsulopathy, which already been mentioned. And keeping shoulder asymmetrical, that is scapular dyskinesia, is one of the very common symptoms we come across in all these patients. So I think everybody suggested about investigation is X-ray. Well, do you all do X-ray, or somebody don't do X-ray? Or is there, what is the point of doing X-ray?
X-ray is a must in every case in my practice.
Anybody disagree with that?
No, we all agree.
I completely agree.
Yeah.
Okay.
Why do you say so? Why do you say so?
If you don't get an X-ray and if you send the patient to say physio or rehab, which has happened in several occasions, there could be several things which could be missed, right from calcific tendinitis, as Dr. Ram mentioned, osteoarthritis of the shoulder.
Absolutely. Sometimes, yes, finish copy.
In few rare cases, there has been a secondary in the shoulder which has been sent to physio, manipulated by the physio, and bone broke, actually ended up with a fracture, not knowing it was a secondary from the lung. The patient presented with pain in the shoulder, typical of frozen shoulder. Only thing, X-ray was not taken.
Yeah.
So everyone has.
Because X-ray, as he suggested, like calcific tendinitis, a flex of calcium will be picked up easily in the X-ray, which is the cause of secondary frozen shoulder, but that can be completely missed in an MRI.
Yeah.
It's not foolproof.
Yes.
So it is always better to have an X-ray, which you can have a look at it, you can interpret it, you can suspect any pathology.
I think I have to say one of the finding that has to be in X-ray, you should not find anything really abnormal.
Yes.
You know the feature in X-ray that you have to look for it in frozen shoulder. And I wonder how many of you will do MRI or CT? For
Subra.
Yeah.
Subra, not infrequently we can come across subacromial spur.
Yes.
I'm seeing an increasing amount of subacromial spurs even in youngsters.
Yes. So about MRI, how many of you will do MRI at this stage?
Only if there is a clinical suspicion of a cuff tear, I do MRI or ultrasound. Otherwise, very straightforward diabetic patient or a clinical presentation of frozen shoulder with a normal X-ray, you could go ahead with a non-operative treatment plan unless the patient doesn't do well with the non-operative treatment, or there is a suspicion of cuff injury, or you suspect any pathology from X-ray. I do MRI.
So, what is the opinion of other panelists?
Chirag?
I would wait for an MRI.
How long? How long? How many months you wait?
So this leads us more towards an adhesive capsulitis, early stages of adhesive capsulitis. The working diagnosis would be that.
Yeah.
So I would initially conserve him, probably put him on anti-inflammatories, physio, wait and watch. If things are getting worse, if the power is decreasing, and persistent symptoms, then I would think about an ultrasound or an MRI.
Right. I put the question in another way. See, this patient clinically looks like frozen shoulder. X-ray is normal. Okay. So you're treating him conservatively. Okay. Would you like to get an MRI in the course of your treatment? 2 months, 3 months later, 4 months later, something like that.
MRI, if it is not settling down at the end of 3 months, I would definitely go in for an MRI.
3 months. Karthik, what about you? Karthik?
Yeah, unless the patient is not responding to treatment. So, the next question is how
1 month, 2 months, 3 months duration.
It looks like the whole panel is agreeing that they will wait for up to about 3 months' time.
3 months.
Is that correct?
See, because the patient has got symptoms for only 1 month, so there is he can wait for 2 to 3 months.
Right. So before
I think literature also confirms what the panel is thinking. Okay, yeah, and literature says up to 3 months you can wait. If they are not getting better, then you can go and do a MRI for ruling out the rotator cuff pathology or rotator cuff tears. Okay. So, what will be the treatment pattern? What is the panel think about treating this particular patient?
I don't think I will go. Okay.
Like Pratap, plan of treatment.
I don't think I will go for an MRI on day one because there's no history of injury, 48-year-old, and he's a active range of movement. So I wait for a couple of months, and if it's getting worse, it's not getting better, then I will go for an MRI scan.
So what is the plan of treatment, Dr. Pratap? This patient 1 month, 1 month old frozen shoulder.
Yeah, okay. You still don't know whether it's a secondary frozen shoulder due to some other reason. So I will treat with the non-operative management like anti-inflammatory and strong analgesics and physiotherapy.
Dr. Ram, what is the plan of treatment?
I think it's pretty clear that it is not secondary frozen shoulder because there is no pathology identified apart from considering frozen shoulder. So I would just stick to non-operative treatment, conservative pain control measures, assisted exercises, particularly focus on the scapular rehab as well.
And do you give an injection?
Well, only if it is pain persisting. At 1 month, if you control the pain, it should be enough in my practice. But if it is persisting painful, I would consider it a subacromial injection.
The whole panel agree that they will not do operation. That's true, isn't it? Yeah. There's no disagreement in that.
Dr.
Yes.
Subramaniam, can you elaborate on your plan of treatment?
No, what I'm saying is, just to confirm with the audience, there is no role of operation or surgery in this particular scenario. That's first thing we want to emphasize. And conservative is the first line of management, and injection is optional depending on the pain of the patient to facilitate the physiotherapy. So, treatment pattern, what I would suggest is definitely it is only the rehab. And a lot of these patients have scapular dyskinesia. And what happens in scapular dyskinesia, there is some anterior tilting of scapula. So the subacromial space also becomes a bit narrower. So it also contributes to the pain. So first line of treatment will be to do the scapular rehab exercises. And just confirm that being it's already working 10 minutes, okay?
Yeah, we'll finish
What we have to do is rehab on specific muscles like anterior deltoid, lat dorsi, levator, lower and middle trapezius, rhomboid, teres major and serratus anterior, and do cuff isometric exercises and do gentle stretching. A lot of the time they do get better and the patients find very satisfactory. So any disagreement with this kind of management pattern from any panelist?
Any panelist?
Absolutely agree. Because the core muscles should be stronger, and then scapular, and then point on the glenohumeral joint.
The one thing I would like to add is when the patient is acutely painful, I wouldn't suggest any aggressive exercises. Sometimes the physios can become over enthusiastic. When the inflammatory phase, if we actually pull on the shoulder too much, the pain might worsen. And I would actually have a lower threshold for injecting the patient. If the patient has got night pain, I would give an injection. For the night pain, the injection works very well, and it also helps the patient do the physio a little better. I would go very gentle with the physio in the initial days, because sometimes patients think that if they do aggressive physio, they'll get better, but sometimes it can actually worsen the pain and prolong the pain as well.
Karthik, I have one question for you. When you mentioned the physiotherapy itself, so it's very well agreed that yes, physiotherapy should be done, not aggressively, gentle capsular stretching. But what would you tell your physiotherapist, which is more important? Would you ask him to do ultrasound or IFT? What is your preference?
No, we don't use any modalities at all.
So just capsular stretching is what you will tell them.
Gentle stretches, yeah. Like
from other speakers, I would like to hear from you the role of ultrasound or IFT in physiotherapy for adhesive capsules.
What is this? Dr. Pratap?
I don't know, is there any difference really between using ultrasound and IFT? I sometimes ask, I don't use modalities regularly, but for those who are not tolerating due to pain, I ask them to use modalities on top of that. Where they usually the physiotherapists try either of them or both also together.
Yeah, one.
Along with ice packs will help also for pain relief.
Can I add on?
Yeah, Chirag.
Yeah, we have moved away from heat modalities. We believe now more in terms of myofascial releases, and of course a good trapezius mobilization and a pec mobilization is very important, along with the scapular stabilization and gentle inferior capsular stretches. This would be our line of treatment initially for these kind of patients. Of course, to add on, Sir Subra sir, any role for gabapentin and oral corticosteroids in your initial stages of your periarthritis?
I don't routinely give any of both of these medicines, either gabapentin or oral steroid. If in case if they need steroid, I sometimes give intra-subacromial injection just for pain relief to help rehab. But I don't have any personal experience on using those. Oral steroid, I don't use it.
You would inject subacromial or in the rotator interval?
I use subacromial.
Okay. Anybody disagree? Anybody disagree?
Yeah.
I give in the glenohumeral joint.
I don't give any injections at all, either intra-articular or subacromial. The only time when I give I will try to give a subacromial injection is if the pain is not settling and is secondary to impingement, and I will make sure that I do an MRI scan before I give an injection. I just want to see the state of the cuff is intact. Only after that I will consider a subacromial injection.
The reason I am subacromial is because usually the impingement is
sorry, we need to move on.
To the physiotherapy.
Yeah, Dr.
So, yeah.
Okay.
I think we'll move on to the next topic.
Okay.
We're already beyond 15 minutes, I think. So, Dr. Ram.
Okay.
Dr. Ram, can you share your screen?
No, I can't. You need to unshare. Subra.
I'll stop sharing.
Hi, Vivek.
Hi, sir. How are you?
Fine.
I didn't want to interrupt and come in between. I thought, okay, let it go on.
Okay, just get this.
In orthopedics, it's a rule. Suddenly, you'll be bombarded with the things when you have a commitment at a specific time.
Exactly. Okay. Right. Can you see that?
Yeah.
Yeah. Okay. So, first of all, thank you, Oasis Committee, for the kind invitation, and thank you, Deepthi Nandan and Chandrasekhar. So, we'll just quickly go to the one case which I wanted to show. A 47-year-old gentleman suffering from Fairbanks disease is actually multiple epiphyseal dysplasia affecting many joints with dwarfism. The patient is about 4.5 feet height. Patient already had bilateral total hip replacement 2 years ago, presenting with painful stiffness of both shoulders. The right side is more symptomatic than the left. So that's the background. There's no history of trauma. He's got difficulty to lift up, reach back, and is beginning to be feeling difficult to carry with activities of daily living, significant neck pain. So with that, I think Subra has clearly covered the reason for painful stiff shoulder could be a primary frozen shoulder or a secondary frozen shoulder or an arthritis or a post-traumatic situation. So with this, the examination findings of this patient, as you see the pictures, he has a right elbow fixed flexion deformity of 70 degrees. Further full flexion is possible. So he's got a problem in the ipsilateral elbow. And the right shoulder, the range of movement is flexion around 100 degrees, abduction 70 degrees, external rotation is 10, internal rotation, it can't, I think I just put T10, it is not T10, it is less than that. And the rotator cuff examination within the current movement shows intact rotator cuff, supraspinatus, resisted external rotation, which is testing infraspinatus, BP, that is belly press test, suggesting subscapularis, all power 5. So this is the scenario. So I agree everyone will proceed with an X-ray, and that is the patient's X-ray. So what is everybody's opinion and how to go about? We start.
Dr. Subramanian.
Brother?
Yeah, it's an interesting case because somebody who has got MED plus dwarfism is already having bilateral THR. So you expect to have other joint pathologies also. Obviously, your right shoulder X-ray showing some calcific shadows under over the inferior aspect and also over the corpus aspect. And generalized, there is rarefaction of bone and degenerative changes are also there. But good thing is subacromial space looks well preserved. There is no proximal migration of the humeral head. And sentence line of the Gothic arch is looking nice.
Yeah. So these the particular set of patients are prone to develop multiple epiphyseal dysplasia and early onset of arthritis in the articular joints, usually shoulder, elbow, hips, and knees, and also dwarfism. The spine usually is preserved. Okay, Karthik, how do you go about it? Further investigation. What is your plan?
Karthik, sir, yeah. So what is the disability of the patient, sir?
Oh, we just showed basically the right shoulder. He's got both shoulder stiff and painful, but the right shoulder is getting worse. Movement is around 70 degrees.
I would like to get an MRI.
MRI. Okay, so I can see that. So that's the
I think MRI shows it much better because we can see that it's almost bone on bone there with a big inferior osteophyte on the humerus. And cuff seems to be thinned, but it is preserved. So the cuff is intact.
Axial images.
So that's the sagittal image.
So the axial image, we can see that there's not much posterior erosion on the glenoid. So
there's a concentric arthritis of the glenohumeral joint, and with a lot of loose bodies, both inferior as well as medial plane. So, what is your Chirag, do you want to do any other investigation? You happy with MRI?
Yes, sir. Good enough, because here the loose bodies are well defined and well shown. In fact, inside the muscle also, inside the subscap, you see a lot of calcification there anteriorly, and it's a concentric glenohumeral joint arthritis.
Okay.
Usually,
Subra, does anybody want to do a CT scan?
We would, as a routine, do it, but in this case, looks like the MRI gives us a fair idea. If we can see the entire width of the scapular spine along with the
yeah, it is. I agree with that. Actually, you would see all the images. We are showing only the representative images here. But in my practice, I just get this patient came with an MRI, but we just normally get a CT, because CT will look give you a little bit more profile image of the glenoid, as well as you could also double confirm that there is no posterior erosion or retroversion of the glenoid. So that's the CT images, just to add. So how to go about this now? 47-year-old young man, multiple epiphyseal dysplasia, dwarfism, primary arthritis, glenoid was mild dysplasia, but concentric arthritis, rotator cuff intact. Remember also, he has got an issue with the right elbow, which I haven't got the x-rays here to show, but he's got some arthritic changes in the right elbow with fixed and 70-degree flexion. So we start.
Dr. Subramanian.
Vivek, any comments to make on the case presentation?
No, I think it's quite clear, sir. It's a very tricky situation. You know, you have brought us, in a very tricky situation. So I don't think any investigation further is required.
It's a brand new case for Oasis.
Yes. So I think the axial section shows that the cartilage is quite a lot thinned out, especially on the glenoid side. The other coronal section showed that there is a humeral lower end osteophyte. Now the question is very simple. I know what you're going to ask. What do you want to do? Are we going to go ahead and replace it, or do the second one, what you have written, arthroscopic debridement? So I would choose at the moment, looking at his age, 47, and reasonable movements preserved. So we can go ahead and do the arthroscopic debridement, loose body removal, extensive release, and discuss with him and give him few years before he is ready for probably replacement. I would not at the moment replace with whatever hemi or total.
I have done arthroscopic CAM procedure. That is a comprehensive arthroscopic management, but that's usually successful for patients having a little bit more of a movement, not with such extensive stiffness.
But he had how much? 100 flexion, some 30 rotation.
Yes. And then you have a fixed flexion deformity of 70 degrees of elbow.
Yeah, but elbow anyway won't change even if you do anything shoulder. So
that's an option. That's an option sort of time buying exercise.
Yeah, because he's 47. That's the whole issue. I mean, definitely replacement is the flavor. That if you do, he'll get a very good painless thing. But the question is how long it will go on. Maybe 10 years.
And secondly, is that arthroscopic debridement will get the pain better, but not necessarily the movement.
Certainly.
Maybe up to 2 years. It may last up to 2 years.
2 to 5 max. 2 to 5 max. Yes.
Subra?
Subramanian, Dr. Subramanian?
This one treatment transient pain relief for a short-term period. If the patient is able to accept that, then we can think about it. Otherwise, I would go in terms of arthroplasty. And the challenge is going to be the stem. The humeral diameter looks very narrow.
Exactly. Yes.
Yeah, that's one important observation.
It's not going to be that easy. Even the smallest stem is very difficult because the very narrowest.
Even resurfacing and stemless, we have to remember that the humerus is not a normal anatomy. Number two, it's a very osteopenic head.
Yes.
So I don't know what will be the hold of those stems, even if you use it. I mean, especially the stemless.
Yes. I think that's important. Yes.
I'm a bit worried about the age and the associated conditions. Definitely, they are prone for osteoporosis. So I'll do an T scoring and start treatment for osteoporosis if needed. And then I'm of course worried about his age. So I will try to buy some time. So I am for arthroscopic debridement, even if I can get a 5-year lease. But patient should understand.
Yes.
I will do a total shoulder replacement on him.
Total shoulder.
Shoulder, okay.
Bite the bullet and go for it. Issue with the glenoid?
I don't think we can offer any any sort of durable solution with the arthroscopy because it's bone on bone already, and I'm sure he's had a shot of couple of corticosteroid injections already. Has he had any injections?
No injections.
No, but what about Hemi, Karthik? What about Hemi?
Yes. Why did you say total? That's the question.
We can talk about Hemi versus total, but to me, I would inject him, and then if he's really keen about preserving, having his own joint, and if he's really oriented towards having a CAM procedure, and he's okay if the pain comes back in 2 to 3 months time, then probably I can do an arthroscopy. But looking at that joint, I'm not very confident that I can give him any durable pain relief with
Chirag, what about you?
Chirag?
I would, if it is the first visit, he's come and seen me with a fairly decent enough range of movement. You told me about 70 degrees of abduction, 100 degrees of forward flexion, some amount of rotations maintained. Conserve him till he becomes painful, and his activity of daily living is affected on a day-to-day routine. Till then, conserve him. And of course, Hemi is out of question. It's either total or conserve.
Okay. Now, any more comments?
Injection. Did you offer injection to him, sir?
Sorry, what's the question? I didn't hear the last.
Injection. Do you offer an injection before proceeding for any surgery?
I didn't. I did. Now, I think I take all the points. Basically,
I have one question, Dr. Ram.
Yes.
Is his pain in the night also, or only on movement?
Night pain also. Night pain. See, basically, this guy has got, remember, he has got a bilateral total replacement 2 years ago and is able to walk without pain. Now he has got both shoulders and the right elbow. So he got multiple disabilities, and he's just wondering whether he could have some movement of the right shoulder. If the pain is better, he might not be much happy. He's exploring option whether I could have some movement in my one of the shoulder at least, so that I could just do something better than nothing. So that was his issue. So I decided to do the arthroplasty because the arthroscopic debridement will get the pain better, but not necessarily a good range of movement.
I think what is important
in this tricky scenario, shoulder replacement. Again, you have to take these points. Whether there is a deformed humerus, short humerus, option of stem is the query. And second thing also is got an elbow problem. So what if we need to do something for the elbow in the future? So if you put a stem, even though smaller, it might even hit the elbow prosthesis. So I think the more key is towards going for resurfacing or stemless, because resurfacing or stemless could be done without altering the body anatomy. So that's the resurfacing popularized by Copeland. That is the early results showing 94% better, 10% revision, of course, but he showed that comparable results to stem to prosthesis, and humeral implant doesn't need a stem or a cement. And these are the different options. But my concern is in here is the rotator cuff is already thin, and there is a risk of overstuffing of the joint and making the glenoid bit more tighter, because he's already have a glenoid. Now, I decided to do Hemi for him. You can argue whole day about whether to Hemi or total, but if you do a total shoulder with a concentric glenoid, there is a risk of glenoid loosening, and you need to revise it in a few years' time, sometime, we don't know. But a Hemi can still work for years as far as it is not done without any overstuffing of the joint. So I decided to do stemless. So in here, we have chosen to do a Eclipse stemless prosthesis. So quickly go to the procedure, a deltopetal approach, short deltopetal approach, subscapular stenotomy, release the shoulder all around, and resect the head, and also remove all the loose bodies. and insert the trunion and the cage. It is an uncemented implant system. And then you insert the humeral head cap. Again, as Vivek pointed out, I used the smallest of the stemless. So you had to measure it. This humerus was smaller, so we put the smallest of the stemless cap, and we repaired the subscap back again. That's showing the repair. That is the post-op. The glenoid side, I just made some few drill holes. I didn't ream it because reaming might make the bone weaker. So that is the incision closure, and then the range of rotation you were able to achieve at the end of the procedure. So that is his 5-year outcome, because he is about to come to see me for the right elbow. He wants to get whether he could have some more movement of the elbow. This is the 5-year stemless hemiarthroplasty. As you see, there is some sort of a cartilage in the glenoid, because you still see a gap that indicates some sort of fibrocartilage. And that is his range of movement. This video was taken last week. So that is the flexion, abduction. You can still see the range of fixed flexion deformity. That's the adduction, abduction, and internal external rotations, and is actually able to use the right arm for all day-to-day purpose, and has got no pain, and that is 5-year outcome follow.
Dr. Ram, then
yes.
So I think we are to move on to the next topic. So I will conclude that.
Finish.
Yes, to the stemless.
That is the last slide, Chandrasekhar. Okay. Stemless shoulder is an option for a stiff arthritic shoulder, especially in a younger age group. Versus resurfacing, it is bone preserving, easy glenoid access as you are resecting the head. There is absolutely no overstuffing of the head. Versus stem, the head placement is independent of the medullary canal or tuberosity anatomy, so you could safely do, and it can avoid stem-related problem in the future. Thank you.
Okay, thank you very much, Dr. Ram, for such a nice presentation and enlightening us, our audience, about the stemless process. I think we have 2 processes available at this moment. Arthrex, it has Eclipse, and then you have Evolutis with the stemless process available in India at this moment. And in fact, I think we should move on to more of stemless process rather than stemmed process, because they are relatively bone preserving. And maybe stemmed process are for those cases where you cannot avoid putting a stem, like fracture cases. Maybe.
More importantly, it preserves the biomechanics.
Yes.
I think it's very surprising. You just remove one of the arthritic surface and how much painless it becomes.
Yes,
that's very, very surprising. Part of the stemless hemis.
Yeah.
You have not yet touched the glenoid. You just remove this. Oh. It has always bewildered me. How does it work? You just remove one irritant surface.
Exactly.
It's different from hip and knee then.
Yes.
Surgical steps are much simpler than conventional anatomic shoulder replacement.
Absolutely.
Yeah, you don't have to worry much
about the next topic. If you excuse, Dr. Chirag, can you speak on stiffness with rotator cuff tear? Chirag. Dr. Chirag, can you share your screen?
Yeah. Can you hear me, sir?
Yeah, I can hear. Yeah.
First of all, I would like to thank the organizing team, Dr. Deepinanda Reddy, Dr. Chandrasekhar sir, Dr. Nitin, for giving us this platform. Since it's a general orthopedic conference, we would look into common case scenarios which we encounter on a day-to-day basis. Cuff tears with stiff shoulder. This has been a challenge for all of us. Let's just quickly look into 2 cases. The most common scenario what we see on a day-to-day basis is typically a 52-year-old, 50-ish housewife, pain since about 5 to 6 months, stiffness of a little more recent onset for about 3 to 4 months time, subtle history of a small history of trauma at home with the self-fall, has been treated with analgesics, physiotherapy, 1 shot of corticosteroid injections. She is global restriction of range of movement while stabilizing the scapula. The abduction is hardly 20 degrees, forward flexion up to about 70 to 80 degrees. Rotations, external rotation is almost nil. Internal rotation very minimal. Cuff strength fairly good enough, but not able to clearly assess because of the pain. And one classical typical sign or is coracoid tenderness. Now, from the panel, do we need imaging for such cases?
Dr. Subramanian? Dr. Subramanian?
Yes, hi. Yes, definitely you have to do a X-ray and MRI scan for these patients.
What is your provisional diagnosis? What is your provisional diagnosis?
Obviously, the patient is in pain and also loss of movement. So already has got adhesive capsulitis. There may be a associated rotator cuff tear also.
What investigation you would like to have?
X-ray and MRI both.
X-ray and MRI. And
Dr.
Ram? Dr. Ram?
I agree with that.
Okay.
Agree with that. We'll get an MRI.
Anybody disagree? Anybody disagree?
Chirag, did you check the strength? Did I miss that part?
Yeah, strength was typically could not assess because of the pain, but yeah, of course, compared to the opposite side, it was weak. Both the empty can and full can signs were weaker compared to the other side.
If we compare with the first case which was discussed, see, if there was no history of fall, if it would have been just an insidious onset of pain and stiffness, I wouldn't have asked for MRI.
Yes.
But here, one, there's a history of fall. You have very categorically mentioned there was a fall. Number two, there is weakness on the cuff strength, because in experienced hand, and I'm sure that all of you will agree, that in experienced hand, you can figure out whether it is a weak shoulder or not, despite having some pain. So if there's a weakness, if there's history of fall, then yes, we must investigate at least with one imaging, either ultrasound or MRI.
So Vivek, you point out that you had differentiated between weakness due to muscle strength weakness and weakness due to pain.
Absolutely. I'm sure that none of all the seniors who have been practicing shoulder for 5 to 10 years can differentiate. You can figure out that this is a very subtle weakness because of pain, and there is a certain weakness because of the cuff tear.
I think we have to add one important point. When you're examining for strength, you have to examine within the range of motion, passive range of motion that is available in the particular patient.
And other thing, what you can do is if such cases, you can actually make them lie down on the couch, then do the full can, because that gives them a reasonable amount of scapular stabilization. Then you can again check. So, and anyway, Chirag mentioned there is history of fall plus weakness. So I think we must do that, because the audience must differentiate that why first case when there was a frozen shoulder, they were not asking MRI. And now in this case, why everybody wants an MRI.
And there is history of trauma also in this particular patient, I think.
Absolutely.
History of subdural trauma. Okay, Chirag, go ahead, please.
X-ray was normal. We did go ahead with the MRI, and this is what our MRI shows. There is a partial thickness rotator cuff tear at the insertion. It's a very, very common finding in most of the MRIs which we get for stiff shoulders with some history of trauma. And of course, some signs of adhesive capsulitis on an axial and sagittal view. The rotator interval is thickened. There's biceps tendonitis, and the inferior axillary pouch is full. Now, treatment options from here. Where do we stand?
Chirag, can you mention about the size of the tear? Can you mention about the size of the tear? It is 5 millimeter, 8 millimeter, 10 millimeter, or something like that?
Partial tear, sir.
Partial
Not a complete tear. No retraction. Partial tear. Articular surface tear. Yeah, articular surface footprint tear.
Yeah, footprint tear maybe less than 10 mm. Let us say.
So we can have a look at the image. It's
yes.
Yeah, it's a small tear.
Yeah, small tear.
Yeah,
small partial articular surface tear with stiffness. Okay. So we'll move on to Dr. Subramanian. What do you like to do?
So this patient's main problem looks like not able to do movements, isn't it? So first option will be to go for rehab and try to get some range of movement before trying for any intervention. When you are trying to go for rehab, if the patient is not able to do the rehab due to pain, I will offer one sort of injection. That will be my plan of action for this particular situation.
One shot of injection is given. Rehab has been done for 3 months.
And if the rehab has already been done, I want to make sure that it's been done properly. That's also very important, because most of the physios do not do it exactly in the way that we like to do it. So make sure it has been done properly. If it has been done properly and still it's not being the patient is not improving, then I should offer surgical intervention. Okay.
So you try rehab, then okay, if rehab fails, what you will do, Dr. Subramanian? If rehab fails, what you will do?
Then I should go for arthroscopic intervention, where you do release and repair together at the same time.
Release and repair at the same time. Okay, we'll go on to Dr. Ram. Dr. Ram.
Yes, I think agree with that. Just partial articular surface tear with stiffness post-traumatic. You can try rehab first, they can get away when the stiffness is better, the pain gets better, they can cope. But if it is not, then I would go ahead with the arthroscopy. It's the high grade partial tear. So depending on the assessment, either I would do an in situ repair or take the bursal layer if it is also degenerative or torn, repair a takedown repair. At the same time, release the capsule.
Karthik, do you agree or disagree? Karthik, can you hear us?
This tear here,
yeah,
the MRI picture, Chirag, if you can go back, that's actually called the rim rent tear. It's very common. Sometimes the radiologists write it. It's right at the most anterior part of the supra attachment to the footprint. And this is very commonly painful and doesn't respond well to conservative management. When patients don't respond to conservative management, I think we do the same thing: release and repair, and then mobilize almost as soon as possible, so that so you do a robust repair. You can't afford to do a whatever possible way you do a very robust repair, so that we can mobilize the patient the next day itself.
Okay, Dr. Vivek.
Yeah, I think I would agree with most of us, except just adding 2 points where the Subra sir asked a very valid point. What is the size of tear? And I would add, what is the location of tear? You see, in the supraspinatus, biomechanically, if the tears are present in the anterior third, which Karthik was trying to actually emphasize, the rim rents are more closer to anterior third. They would not respond usually to conservative treatment. So in the sagittal section, Chirag, if you could have put up a sagittal section there, you can actually see the tear, whether it is in anterior third, middle third, or posterior third. If the tears are located in anterior third, middle third part, then they would not really respond well to the conservative treatment, and they'll keep chewing you. So after failure of this conservative treatment, surgery is an option. But if the tears are in posterior third, you can still prolong, give a short of injection, which Subra sir was saying, and then try conservative. But
if you're operating, what will you do?
Usually located a bit more anteriorly, and they don't respond well.
Now, if you're operating, what will you do?
No, I would do the same what Karthik said. One, you release, as Ram said, and then do a robust repair so that you mobilize them very fast. And that was one thing which should be the part of counseling, that these people sometimes remain stiffer and painful for a prolonged period, despite, whatever best you do, they still remain a bit painful.
Vivek, is there any possibility that you leave the tear alone? Could it be an incidental finding?
No. This one doesn't looks like a very incidental finding. See, the question is, Chandra, once you go in and if you find a close to a centimeter big tear, because I believe once you debride and all, it will become almost a centimeter, 8-9 mm. It's very difficult for a surgeon to leave a 1 centimeter tear.
Chandra,
please.
Chandra, this I completely agree with the Karthik. I'm worried about these sort of combination ones, frozen shoulder with the cuff tear. As you said, it's always anterior cable is lost, and that is where the lot of synovitis, along with the bicipital groove, synovitis acting and the degenerative tear of the anterior cable. So it's not going to heal by itself. If you do a capsular release, you won't get an active range of movement of the supraspinatus. So I will go for an early repair and then capsular release.
My question to all of you is different. Do you in such cases, you do find some amount of inflammation around the biceps tendon? Do you ever do biceps tenotomy in a 50, 51, 52 around men and women?
No. We will always see that, but I won't.
Okay.
Vivek, I am not the panelist, I'm the moderator, but I would like to make a small comment on this. These kind of small tears, I tend to neglect them, in the sense when I'm doing arthroscopy, except those anterior 1/3 tears of supraspinatus, which are very painful and close to the biceps fully. I think if it's mid-third, even mid-third, or posterior third, a small tear less than 1 centimeter, I tend to leave them alone. Not just partial tears. Partial tears, in fact, I won't repair. It's my personal experience. With a partial tear, given the same scenario, I would like to treat this more like an adhesive capsulitis. The tear could be traumatic and it could be incidental also sometimes. And many times, if you see your MRI scans, when you write an MRI scan for a stiff shoulder, you will get a report of a partial tear of supraspinatus.
Yes.
So sometimes I do believe that these kind of tears can be incidental, or sometimes even to their post-traumatic also, they may not be so consequential. The post-trauma stiff shoulder is more important, and the patient may be in fact suffering from frozen shoulder. So I tend to treat these patients more in terms of adhesive capsulitis, given injection, rehab, not improving. I have done arthroscopy. I did only capsular release, and the patients did very well. Then they never came back to me for the cuff repair. In fact, I had few patients with large tears, more than 2-3 centimeters tears, with very stiff shoulders, where I've done just capsular release and explained to them if necessary they have to go for a cuff repair in future, but never came back to me. They were doing very well. So I believe there's a subset of patients with compensated tears where we have to be careful in repairing. So one question here is that if a patient comes with stiffness and a cuff tear, if the severity of the stiffness will tell you whether to really have to go for a cuff repair at the same time or not. If you say there's a mild stiffness, moderate stiffness, or severe stiffness of the shoulder, because there is some guidelines from niche shoulder course.
So
we say if the passive forward elevation of a particular patient is less than 120 degree, and the patient has a cuff tear, if the passive forward elevation is less than 120 degree, tend not to do cuff repair at the same time. Do a capsule release first, get his range of motion, and then try to repair it. This may be especially true in a small tear, because in a small tear, we don't expect the tear to get retracted very soon. It may take a lot of time for the tear to get retracted. If it's a large, massive tear, probably in a worry that if we leave the tear alone, the tear tends to get retracted, and we cannot repair it in future. But a small tear, I am not worried so much. I leave the tear alone, just do a capsule release, keep the patient on physio, and if the patient ever comes back to me with cuff symptoms, probably I tend to repair the small tear. So
that is what in some we were trying to discuss, and that's what Ram and others also said. See, these are, if you are, in my experience, which as you very rightly said, a lot of patients will have smaller tears, and actually no one operates for those small little insignificant tears. Never we have done, number one. Number two, if the tear is in anterior third, the question was what will happen? So they keep on chewing, you go inside, you do a good repair and you mobilize them. You exactly mobilize the same fashion the way you would do for the frozen shoulder. You don't worry, you start the active mobilization. You ignore, even if it re-tears, let it re-tear. The number three thing is which kind of tear I ignore, if at all we are going. The tear which you have to literally probe, ye kahan hai, where is that? These are usually high grade tears. So I don't know. I mean, you are 100% right. Actually, if you don't repair them, nothing will happen. They eventually become all right. But the question is, when you've gone in, okay, put 2 anchors, repair it, and mobilize fast. It's okay.
Okay. But just a small observation is that as the patient with the frozen shoulder, you are doing release or whatever, if in those occasions you see a partial articular surface fibrillation or cuff tear, we tend to leave it. Because the primary pathology is the stiff shoulder presentation, pain and stiff. But here, there is a clear history of trauma and the tear, and there is not much of a tendinosis changes. This is actually like a avulsion of the articular surface of the cuff anteriorly. Yes, and the anterior cable has avulsed. So I think that we have a little bit more low threshold to repair this particular scenario. Yes, Chirag.
So we did go ahead. We did rotator interval release. One tricky situation here was the patient just did not want immobilization post surgery.
Yes.
Her main complaint was not the pain. She's like, I cannot do my activities, household activities, housewife, and I gave her an option of a repair, but these patients are so fed up with stiffness that she was very reluctant. So what I did, I did a subacromial decompression, thorough 360-degree release, and mobilized her. And post, of course, we did a subacromial decompression, which I believe will act like a natural PRP. But then again, at 6 weeks, I went ahead and put in a PRP injection there. She is happy, doing well, a good rehab. She's doing her household activities, and she is definitely well. These small tears in the footprint, I tend to leave them rather than open them up. If as Vivek sir rightly said, if you have to probe and find where the tear is, such tears with stiffness, you do not open it. And to justify that, we have a very good paper from Sugaya. This is a landmark paper where he says they studied about 378 shoulders, and they conclude that any patients who have global restriction of movement, this is exactly where our patients do fall into, usually have a small partial thickness tear. They never have a full thickness tear. And they say that do not even go to image this. According to them, if the patient has a global restriction of movement, that is forward flexion less than 100 degrees and external rotation less than 10 degrees, they say don't even go to image them, conserve them. And yeah.
I'll just interrupt for a second. That's what exactly Ram and Pratap and others were trying to say in the first case, that in a normal frozen shoulder, typical idiopathic frozen shoulder, don't image them because the radiologist will report something. And the minute it is reported, you are thoroughly confused.
Yes.
Okay, some partial lesions, some biceps and synovitis, type 2 slap tear, and you start itching that what to do.
Yeah. So that's so probably I think we should go by our clinical judgments and arthroscopic findings rather than going by the radiology, because most of them say high grade rotator cuff tear. Now, what is a high grade rotator cuff tear? It's subjective. So just an extension of
Chirag,
I'll quickly brush to an extension of, yeah.
I think we are overshooting. Probably have to go to the next speaker.
Yeah.
Just one message for the audience is that to interpret that literature, a stiff shoulder patient having a small partial tear is different compared to somebody having a trauma and tearing the cuff and developing stiffness, because that becomes a secondary frozen shoulder. I think you have to make that clinical segregation.
Yeah. Yes. Thank you, Chirag. Thank you for enlightening us on stiffness with the rotator cuff tears. We do come across in both the ways, a cuff tear with stiffness or a stiff shoulder where we see an MRI scan, a small tear. And we move on to Dr. Karthik Selvaraj from Medwin Hospital, Coimbatore. Karthik. Karthik, can you share your screen?
Yes, sir. Yes. So can you all see my screen? Yeah.
Yeah. Yeah, we can see.
So,
yeah, please.
My case will be just an extension of all this discussion we've had, the wonderful discussion and all the take homes we've had. It's just a revision of that. So this is a 34-year-old male. He's an office worker, recreational badminton player. He's been having pain in the left shoulder for 6 months. Had physiotherapy, no relief. Had an injection also. The injection gave him 2 days of relief, but nothing much. And this is how he presents to us. So this discussion is about shoulder, whatever we call as shoulder impingement. It's a very common term used among the physios, the doctors, and even now the patients have picked up this term, and they also talk about this. So this is the scenario. So from the previous discussions, this is a 34-year-old male, again with a painful shoulder. So the discussion here is going to be about the clinical tests, investigations, treatment. So I'll go with the best clinical test to detect impingement. Maybe Dr. Ram can start. Dr. Chandrasekhar, if you want to take over.
I think that this is a slightly different scenario where there's a young athletic population having pain after playing badminton. I would be suspecting instability as a cause of the pain rather than impingement. So basically, it could be like a slap tear or anterior labral tear. That could be the cause as well. So I need a complete examination of the shoulder with all instability tests for him. Like check for anterior instability, slap test, and then finally come to impingement.
Absolutely spot on. Absolutely spot on. It was not meant to be a trick question, Dr. Ram, but I think you started it off very well. So it's a young patient, a totally different scenario compared to a middle-aged woman or a middle-aged man coming with shoulder pain. The youngish patient, physically active, a sportsman. So as we all would do, we would do the complete set of clinical examination for him, including all the instability tests, to make sure that the patients we are not missing any subtle instability in this patient.
Vivek, you have something to say, Vivek?
Yeah, Karthik, I think one important, because this will be played later for the audience, one important message has to go that impingement is not a diagnosis.
Yes.
Impingement is a pathological phenomena which happens because of something happening in shoulder. Frozen shoulder can cause impingement, rotator cuff tear can cause impingement, slap tears can cause impingement, posterolateral tear, internal impingement. I mean, anything can cause this impingement of structures between the head of humerus and this. So I think that once the patient say, I've got impingement, they should be just shut up. And we must find out why it is impinging. And as Ram very pointedly, rightly said that this early age, late 20s to early 30s, labral tear, in the very broader way, whether superior, anterior, posterior, are the one of the cause where they come with this vague pain and you keep on thinking what's going on.
Yeah. So how will you proceed doing your clinical tests for this patient, Dr. Pandey? What all tests will you do? How will you sequentially do your tests?
Karthik, can I interfere for a minute?
Sure, sir.
Hello?
Yes,
Karthik?
sir.
Yeah, we can hear you, sir. We hear you.
No, yeah. Oh, I completely agree with what Vivek said. Impeachment is a household name now. Everyone, most of the guys know what is impeachment. There's something happening. Previously, it was a frozen shoulder. Everyone comes with the diagnosis of frozen shoulder. Nowadays, they come with the diagnosis of impeachment. In this scenario, two things I want to roll out is one is the internal impeachment and second is a slap. He's a recreational sports guy. So these two things I want to roll out. Thank you.
Are there any specific complaints the patient would tell if he is a person with subtle instability or slap?
Difficulty in throwing.
Exactly right.
Yeah.
Exactly right. So if he was a cricketer, he would say he's able to bowl, but overhead throwing at this area, he's not able to generate the power. If he's a volleyball, underarm throwing is fine. So these are things which the patient would say during the history taking that we should be keen to pick up. That difficulty in throwing, as you pointed out, is a indicative of a labral pathology. So are there any other things that the other faculty want to add in clinical examination of a young male with painful shoulder?
So you have to look for capsular tightness, Karthik, because most of these warhead athletes, they have a posterior capsular tightness. In fact, most of us know that the posterior capsular tightness is the first pathology which will start the spectrum of injuries like the posterior superior labral tear and partial tear of supraspinatus, etc. So what we call the internal impingement. So we should specifically look for capsular tightness, especially the posterior capsular tightness.
So how would you test for capsular tightness, Dr. Chandrasekhar?
In supine position, with the arm abducted, and check for the internal rotation both the sides.
Yeah. So
can I?
Yes, sure.
Yeah. So this is
just abducted and external rotated like this, and then you can actually move them into an internal rotated position like this. Check for internal on the normal side versus the affected side, and that's what we call as the glenohumeral interrotation deficit. Now, the glenohumeral interrotation deficit can also have an external deficit on the same side, which is called the total range of motion deficit. So this is a very, very important thing which you need to elicit during your examination. Yes, Chirag.
It is the same thing which I wanted to say. The humeral interrotation deficit is something which we have to do in supine position, and most of these overhead athletes, what we are seeing right now, do have this, and they persistently complain of pain, especially the people who are playing badminton. Typical.
Excellent. I think this discussion is
what next test? Let us move to the next test. What are we going to do next? The clinical examination is over. What you would like to do? Investigations.
So this is the patient. Always examine the back. I think right from the first case we have been trying to tell that just disrobe the patient and then examine his back. As you can see, he's got a very abnormal scapular movement on the left side. And so the scapular dyskinesis per se is not the cause for anything. It could be a cause or it could be actually a consequence of pathology inside. So we just need to document this scapular position for this patient. So we need to look at the back of the patient. Patient with winging has presented as impingement, and these patients with the winging of scapula have undergone subacromial decompression surgeries also sometimes, not even knowing that this is a patient with an axillary nerve palsy or a long thoracic nerve palsy. So always look at the back of the shoulder to see if the scapula is moving normally. That's very important. And the scapula, we all know, is a very prime important mover of the whole shoulder complex. The other thing I want to emphasize is the posture. So a lot of these patients, young patients who come, they all, most of them are office goers, or they drive long distances. Sometimes they are sitting in the desk and working on their computers. So they all have bad posture. So posture itself can actually contribute to impingement. As Dr. Subra in his talk showed the illustration in which you can see that the scapula tilts forward if you have a bad posture. If you have a hunched posture, the capsule actually becomes loose and your cuff has to overact. So the cuff keeps on working, and that actually can lead to tendinosis and secondary impingement. And the scapula tilting forward can lead to reduced space between the acromion and the humeral, and that can lead to impingement. So I think all of us look for a trapezius trigger, a trigger at the supromedial angle of the scapula. And if you find a very tight trigger in these areas, the patients, once the trigger is released, much of the symptoms actually disappear. And if you correct their posture, give them scapular stabilization exercises, I think they all become better. So this is what we were talking about, checking for tightness of their pec minor. Basically, because of bad posture, they can actually develop a tightness in the front. It could be a pec minor or a pec major tightness. There can be actually a trigger in the pec major also, sometimes even in the lat dorsi. And this is what we call as the upper cross syndrome, which is a combination of all this: overactive muscles and upper trap overactivity and weakened scapular stabilizers, leading to what we call as the upper cross syndrome. This is not an uncommon situation. We see this in all our patients who come with complaints of shoulder pain and impingement. But then if you put your hand on their trap or scapula, you find all these painful knots there, and their muscles are weak. And then if you just correct their posture, stretch their capsule, and strengthen the infra anteriors, these patients actually get much better. So this kinetic chain was already emphasized. So this case discussion was also to show the different types of exercises. I'm just going quickly through these as well. These are some of the common exercises which we give our patients for scapular setting. This is called the YTML exercises. So we keep on talking about scapular setting again and again. For a general orthopod, they might not be aware what exercises to give the patients. These are simple prone laying exercises for the scapula. And you have to do manual stretches for the inferior capsule and the anterior capsule, like the sleeper stretches. So that's something I want to tell. Is there anything to add regarding exercises and assessment for these patients who have got posture related, trapezius and scapular related impingement-like syndrome? Basically, this is, I think, probably the commonest sort of patients we see in our practice. So this.
Thank you. I think it's good.
Did this particular patient had any findings intra-articular in the MRI or assessment?
No MRI was taken.
Okay.
This just continued with the physiotherapy for scapular setting and core strengthening, and slowly progressing to.
I do disagree at this point, Karthik, but I think 6 months down the line, I think we should get an MRI. But of course, our threshold for operating this patient will be very, very high. I think most of these warrior athletes, we try to manage them conservatively, unless the pathology is so gross. Stopping his overhead activity. I think I hope that all the panelists accept that most of these overhead athletes, we tend to treat them conservatively as much as possible. Only in the last resort, we tend to operate on them. Any difference of opinion?
Before you conclude, I'll just ask others also.
Yeah.
6 months down the line, somebody comes with a continuous painful shoulder. Of course, we do the clinical examination, make some judgment, because all these scapular dyskinesia, tight pec minor, they could be secondary to something going on. So how many of us actually will do an MRI? See, we may still manage conservatively. Nobody puts a scope in these patients, but at least, I would go ahead and do an MRI once. Yes, sometimes you have nothing much to say. You have just capsular tightness, no clicks, no joint line tenderness, nothing much to say that there may be intra-articular pathology. But if I have slightest of doubt,
and this also helps to reassure the athlete and the coach and the trainer that there is nothing wrong. You can work more, you can build up the muscles more. Otherwise, they'll be having the constant worry as well in the back of the brain.
And if you not do, somebody else will do.
Just to add one more point, what Karthik was emphasizing on scapula, I have something called scapular assistance test.
Yes.
Itself. There, if somebody has got a prominent scapula, infromedial body is prominent, you try to push the scapula back in normal place and try to do your impingement test. It becomes negative after that. That actually gives reassurance to the patient that on doing rehab, their symptom is going to improve. So that's the only thing that I would like to add for you. But you narrated very nicely about the whole scapula mechanism. Thank you.
I totally agree with Dr. Vivek and Dr. Ram that an MRI will actually give us more information of what is happening in the glenohumeral joint. And most of the times we tend to get an MRI done, especially in a professional athlete. In a professional athlete, they are very, because they're very disabled and they are unable to throw, they are unable to generate power there. There could be a labral tear there. So these are in a professional athlete or an elite athlete who wants to go back to sport quickly. That's the patient who would actually, we would always worry about a structural lesion. But in a recreational athlete, an office goer, the predominant treatment would be physiotherapy. So if you find a type 2 slap in a patient who's like a 34-year-old sedentary office goer who's got pain and is unable to play his weekend sport, you find a small slap tear, or it's called a type 2 slap tear on thing. Now, anyway, we are going to rehab him for some time at least. So these are patients whom I would actually give 1 month of proper, sincere religious rehab. And if they don't respond at all, then I go back to, and they definitely go and get an MRI done. Whereas in an elite athlete, I would straight away get an MRI, as you all suggested, get an MRI done, see if there is any structural lesion, and then again put him on rehab, and then rehab him as much as possible. And then, so these are the various MRI reports we get in patients who actually are labeled impingement. It can be tendinitis, sometimes called as tendinitis, but tendinosis mostly. There can be a small partial thickness tear. There can be a slap, and AC joint can be involved as well. So I would actually, so Chirag actually brought out this point about PRP. I just want to get the panel's opinion about PRP injection.
Karthik, sorry to interrupt. We are running short of time.
Yes, and concluding, I just want to know, is this PRP a real thing? I mean, how many of you give PRP? Just a show of hands, or yes or no, just.
It is not a real thing.
No.
Right. That's it. So I'm concluding, suspect instability as a cause of impingement in a young patient. So that's the most important thing if you're going to take home from this. And this is just the gist of all the other things. Thank you very
much. Thank you, Karthik. Thank you. That's a nice take-home message. So we'll move on to next.
Thank you, everybody, for the active participation. I think we are running short of time, so I'm cutting short the program. But thank you very much for the whole of the national faculty for a brilliant program. And we should do this sort of programs more often in the future. I think we will meet up again. Thanks a lot. Bye.
Thank you, sir. Are they going to direct us to validatory function now?
The validate is actually finished. We are running it parallel, so it's all done.
Okay, so all done.
It's all finished. Yeah. Thank you, Chandrasekhar.
Thank you, sir. Thank you, sir. Bye, bye.